So, sir, it's three, two, one. We are live now. Over to you, sir.
Good morning. We are here again on Sunday at 11:30 of the month of January 2025. A new year, a new beginning, and FOGSI ICOG PG Clinic is here for its another edition. We are thankful and grateful to the FOGSI President, Dr. Sunita Tendulwarkar, and FOGSI ICOG Chairperson, Dr. Parag Biniwala, Secretary General Dr. Suvarna Khadilkar, Secretary of ICOG Dr. Sarita Bhalerao, for giving us this opportunity to continue with the ICOG PG Clinic program. We are having this program for last 3 years, and this time also we have come with some modification, and we have added quiz for the students in the end for half an hour, and this will generate lot of interest and give knowledge and information to the student also. So today I have with me Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman as a coordinator of this program. And we are having, as we have told you earlier also, we are having three part in which first session is on the doll and dummy. And today we are having fetal skull and maternal pelvis, non-rotation and mal-rotation of occipito-posterior position by Dr. Ashish Mukhopadhyay. Then we will be having a case on AUB, and we have faculty Dr. Ashish, Dr. Shruti Bhaskaran, Dr. Shobha Gudi, and Dr. Manika Agarwal. Then in the how to do it and to learn the skill, we have Dr. Nalini Mishra, and she will be teaching us about the balloon tamponade, and she is the person who has developed Chhattisgarh balloon, Foolish balloon tamponade method from this country. And in the end, we have postgraduate quiz by Dr. Archana Kumari. So without any further delay, I invite Chairperson of ICOG, Dr. Parag Biniwala, to inaugurate this program and give his blessing to this program. Dr. Parag Biniwala, sir.
Thank you, Dr. Ashok. Good morning. I bring greetings from ICOG, and it's indeed a pleasure to address you all as the chairman of the ICOG. This is one program which has entered the fourth year of its existence, and I must appreciate and thank Dr. Ashok Kumar, Dr. Ashish Kumar Mukhopadhyay, and Dr. Hafizur Rahman, who spent all their second Sundays with ICOG educating students and imparting knowledge. I must appreciate that. Doing the same activity for 3 years, it's not easy, and this is the fourth year, and I'm sure you will do wonderfully well even this year. I must thank all the examiners for sparing their time, Dr. Ashish, Dr. Shruti, Dr. Shobha, and Dr. Manika. And I'm looking forward to the lecture by Dr. Nalini Mishra. I happened to interact with her about 3 years ago when she did present this for the first time. And this is something so useful, so doable, and at the same time so affordable, especially in our country where PPH is a major challenge. Special appreciation to Dr. G. Tenimoy, who's the professor at the Chengalpattu Medical College, for getting students to present this. And the add-on element that we have today is the quiz. I must appreciate the quiz committee led by Dr. Archana Kumari and immediate past chair, Dr. Nilesh Balkaude, who will be conducting quiz every time. Thank you, Team Aristo, Mr. Ramnath, and all of the team for collaborating with us. And of course, all the quiz winners will receive a book very, very soon, courtesy Team Aristo. I take this opportunity to invite all of you, all the teachers as well as students to Pune on the 1st and 2nd of March 2025 for the ICOG annual conference, the 10th ICOG annual conference, where we can personally meet, learn from the experts, and get enriched. Thank you very much and all the best for the program.
Thank you, Dr. Parag Biniwale, sir. And I just inform everyone, today I am doing this program from our ICOG office at Mumbai. We are here for certificate course meeting and examination. So first time in this fourth year, we are doing this program from ICOG office, and we are live from here from Mumbai. So now I request Dr. Ashish Mukhopadhyay sir to say a few words, and then we'll start with the program.
Namaskar, and thank you very much, Dr. Parag Biniwale, our ICOG chairperson, FOGSI President Dr. Sunita Tendulwar, Secretary General and ICOG Secretary, and my co-coordinators, Dr. Ashok Kumar and Dr. Hafizur Rahman. Well, this is the fourth year, as everyone said in the beginning, that we are marching ahead with this program. And I'm especially thankful to the President FOGSI and the ICOG chair, because this shows their importance put into the PG education, especially the exam-oriented education. And I believe that we are selecting the topics according to their convenience and according to their applicability in examination. So exam-oriented. And another component very wisely and nicely added by our ICOG chair, Dr. Parag Biniwale, is the quiz, which will be extremely useful, thoughtful, and very interactive among the students. Quiz always generates interest among the students. So I'm very thankful to Dr. Parag Biniwale for this effort. And I thank you from the bottom of my heart. And I would like to continue this effort. And thank you very much for selecting us, the trio, for continuing with this PG medical education program. Thank you very much. Dr. Hafizur, to start the program, please. Unmute yourself.
Yeah. Thank you so much, sir. Good morning to everyone. As Ashok sir and Ashish sir said, that is, we are thankful to FOGSI President as well as ICOG Chairperson Dr. Parag Biniwale sir for allowing us and giving opportunity to continue this program. We told that this program is in fourth year, so all the program previous recordings are in the ICOG website, so everyone can go and have a whenever they want to have a look on it. Now, as is planned, that is the first session is one of the most important session. That is the session on dummy and pelvis that every student they face in the examination. So that program will be by none other than Dr. Ashish Mukhopadhyay sir on malrotation and occipita posterior, malrotation and non-rotation of occipita posterior position. Now, second session is another important session where we usually continue with our case discussion. That is the students are Dr. Meneka, Dr. Gayatri, and Dr. Shruti. They are from Chengalpattu Medical College, Chengalpattu, Tamil Nadu. And they have been guided by their professor and head, Dr. G. Thanmoji, madam. And we have vastly experienced professors, or rather I will say the examiners, Dr. Ashish Mukhopadhyay sir. So sir is principal and professor of CSS College OBGYN at Health at Kolkata, West Bengal. Sir has been actively associated with this program from last 3 years. Then we have Dr. Shruti Bhaskaran. Madam is professor of obstetrics and gynecology at UCMS and GTB Hospital, New Delhi. We have Dr. Shobha Godi, madam. Madam is senior consultant at Manipal Hospital, Bangalore, and as well as the ICOG Governing Council member. Then we have Dr. Professor Monica Agarwal. Madam is professor at OBGYN of Negrin, Shillong. She is also experienced in this. Now, as Parag sir and Ashok sir said, that we are going to look after this Chhattisgarh balloon that will be covered by Dr. Nalini Mishra, madam. Madam is presently Dean and Professor at Allen Medical College and JK Super Specialty Hospital, Bhopal. She was previously ex-HOD, Government Medical College, Chhattisgarh. So we'll have this session, and the last session is the attractive, that is postgraduate quiz on abnormal uterine bleeding. So I'd like to request all the students to tune to the last to have the quiz by Dr. Archana Kumari and Dr. Rijesh Ravi. So I don't want to waste more time and would request Ashish sir to cover the start on the first session, that is with the non-rotation and malrotation of occipita posterior position, what is with the dummy and pelvis, as well as practical tips to the students. I am sure this will give mastery experience to the students and it will be helpful for their examination purpose as well. Over to you, Ashish sir, please.
Thank you, Hafizur. And here we begin today's session on dummy doll and pelvis. And there is no need to share screen here. I'll just show it everything on the direct video. So I would like the organizer to focus on me and the pelvis so that we can demonstrate the steps of the malrotation, non-rotation, and their management properly. So here is it. All know how to hold the pelvis. We all hold the pelvis in anatomical position, particularly in exam, because the examiners always want that. Okay, so this is the way you hold the pelvis in anatomical position. Kindly focus on this pelvis only. Yes.
Yeah, Mr. Ramnath, can you make Ashish sir as to highlight and spotlight rather?
Yes, sir. Done, sir. Done, sir.
Sir, Ashish sir, can you push your camera a little bit up? Yeah, now it is better.
Yeah. So
Perfect, sir. Perfect.
we have discussed in the previous classes, as far as I remember, that the occipital posterior is one of the malpositions. What is a malposition? Normal position is that the can't see myself. Suddenly it is gone. I'm sorry because of the phone call. Okay. So normally we know that when the occiput stays anteriorly, that means like this, or laterally. So occiput in the anterior segment, anterior quadrant, either right or left or lateral, we call it normal position. When the occiput
sir,
can you see?
Sir, yeah, sir, that much. A little bit of distance from the camera. I think this much is okay. Sometimes it comes a little closer. Now it is okay, sir.
So this is the occipital anterior position, and this is the occipital lateral, also called the anterior position. This is the right side, and this is the left side. But when this occiput is placed posteriorly towards the sacrum, we call it malposition, because our abnormal labor starts from here. The occiput has to stay anteriorly. Whenever it goes posteriorly, it becomes an occipital posterior and a malposition. Now, what are the problems this malposition can cause? Malposition is also associated with non-engagement or delayed engagement of the head, occipital posterior. And in fact, occipital posterior is the commonest cause of non-engagement or delayed engagement at term in laboring women. So that is the first thing. Now, what are the causes of this malposition? Why is the occiput placed posteriorly? The first cause I must mention is the defective pelvic architecture, where in cases where the space is limited anteriorly, the space is there more on the posterior segment, so the occiput, or the wider part of the head, it is pushed posteriorly. We also know that the ROP, or right occipital posterior, is 5 times commoner than LOP. That is because of the number 1, dextrotation of the uterus, and number 2, because of the presence of the sigmoid colon on the left side. So these are the reasons why the occipital posterior happens. So this is a malposition, not a malpresentation. Remember, malpresentation is not a malpresentation. Presentation is always cephalic here also, but the position of the occiput is abnormal. That is why we call it a malposition. Now, as I said, in the previous class we have discussed in the ROP position of the fetal head. This is the ROP position of the fetal head. When the occiput is placed posteriorly along the right oblique diameter of the pelvis. So this is the right oblique diameter of the pelvis. Now, obviously, the head is not in a flexed condition, which happens anteriorly. When the occiput is anterior, the head is totally flexed. But here in occipital posterior, flexion cannot happen because of the presence of the maternal spine here, and also the projection of the pregnant uterus anteriorly. So it has to be a deflection. The opposite of flexion is called deflection, the severe degree of which is called extension. So today we are going to discuss deflection. What is deflection? Basically, I will show you with the head isolated way. Okay. So this is the occiput which is placed anteriorly. Suppose this is the pelvis. This is the pelvis anteriorly. We call it occipital anterior, and this is occipital posterior. I will show you with the occipital posterior, right occipital posterior. Now, in occipital posterior, as I said, the spine is there, which prevents the flexion, fetal flexion. So deflection will be there. So deflection is a mandatory presence in occipital posterior. Now, this deflection can be mild, moderate, or severe. Now, when it is mild, the occiput is posteriorly like this. When it is mild degree of deflection, then what happens? The occiput is the lower pole, sinciput is the higher pole. So occiput is the leading pole. But when there is a moderate degree of deflection, occiput and sinciput, they are almost on the same plane. So there is no leading pole here. And when it is further deflexed, almost extension, the sinciput is the leading pole and occiput is not the leading pole. So these are the changes which happen associated with the occipital posterior position. So degree of deflection actually decides the fate of delivery in case of occipital posterior. So this is the problem with the flexion of the fetal head, which cannot happen because of the maternal spine and also because of the uterus. So what will happen? The occiput will now try to come anteriorly so that it can be, delivered as a normal anterior delivery or normal vertex presentation delivery. So in the process, what happens if the pelvis is adequate, or I should say reasonably adequate, because if the pelvis is adequate, occipital posterior in the beginning will not happen. So in the cases, 90% of cases, what happens? This occiput, which was there here, it rotates through 3/8 of a circle anteriorly to bring the subocciput under the symphysis pubis. You can see the spotted area is the occiput, subocciput. This hinges under the symphysis pubis. This is called a long internal rotation. So from this position, ROP position, the head rotates through 3/8 of a circle anteriorly to bring it under the symphysis pubis. Now, this is called internal rotation. Now, coming back to the mechanism of labor, what happens in case of occipital posterior is that there is engagement. Engagement will be delayed because, as I said, because of the deflection, the engaging diameter is different. In cases of anterior, we see that the suboccipitobregmatic is the diameter of engagement. This is the anterior. But in cases of deflexed head, suboccipitobregmatic doesn't become the leading diameter, and in its place, suboccipitofrontal diameter, which is more than 9.5, 10 centimeter, becomes the engaging diameter. With further deflection, further more occipitofrontal and other diameters will come into play. So there is a delayed engagement even after the process of labor has started. So there is delayed engagement because of the longer diameter in the right oblique diameter of the pelvis, which is 12 centimeter. So that is the first thing. The second thing is that, as I said, as the occiput, which is still the leading pole, touches the pelvic floor and then rotates through 3/8 of a circle anteriorly to bring the subocciput under symphysis pubis, this will obviously take 3 times the normal time taken for the internal rotation of 1/8 of a circle, and therefore the internal rotation also takes a longer time. So from the very beginning, the woman is exposed to a condition of prolonged labor. And you must understand this and properly and adequately give assurance to the woman, because as she looks around, all other laboring women, they are delivering one after another, and she's still lying on the labor bed. It's very uncomfortable for her. And particularly when the occipital posterior causes excruciating pain because of the pressure of the occiput towards the back. So you need to comfort the woman, give her tender, loving care, and the accompanying person who is accompanying her in labor must be assured about a delivery, which is maybe taking a longer time, but it will ultimately deliver in a normal way. So this we must ensure. And this also should be adequately informed to the patient parties who are waiting outside, because they are also worried that our woman is not delivering till now. So much time has been gone. So extreme important is the counseling and giving support and comfort to the woman. A timely enema if the bowel are not emptied in the morning. So I think that is very important. Otherwise, this pain will be more unbearable. And the position of the woman should be to her choice, according to her choice. But her movement should be restricted because of the fear of early rupture of membrane or cord prolapse. So these are the management tips that we should follow in a case of occipito-posterior in labor, in first stage of labor. But remember, before that, one important issue is that this case assessment of occipito-posterior in labor should be assessed by a senior obstetrician, because the adequacy of the pelvis for this baby has to be established, and each case has to be judged by its own merit. So I think that the management of the labor of a case of occipito-posterior demands that a careful assessment by a senior obstetrician around, and also the presence of facilities of instrumental vaginal delivery, which happens at an increased rate in these cases. Roughly 10% of all women will have occipito-posterior position, so we need to be careful about these cases. Now, coming back to the mechanism once again, after the occipito-posterior touches the pelvic floor, I mean the occiput touches the pelvic floor, it rotates through 3/8 of a circle anteriorly to bring the subocciput under the symphysis pubis. And then rest of the mechanism of labor is almost the same as occiput anterior. So there is nothing much in it. We have already discussed that. Now let us come to the cases where this doesn't happen. Remember, 90% of the cases this thing happens. That means the occiput rotates anteriorly, leading to a favorable outcome. But in 10% of cases, non-rotation or malrotation of the fetal head happens, which is the topic of discussion today. Let us take the first case. In the first case, in the occipito-posterior position, what happens? I'll show you with this. In the occipito-posterior first position, what will happen? This occiput is marginally lower than the synciput. So the occiput is the leading pole, all right, but only by a small margin. That means the degree of deflection is mild. So what happens? The occiput tries to rotate through the 3/8 of a circle anteriorly to bring the subocciput under the symphysis pubis. But in the process, what happens? The occiput, as soon as it becomes lateral or transverse, it also sees that on the opposite side, the synciput has touched the pelvic floor. Because the difference between the occiput and synciput being marginal, it has allowed both the occiput and synciput touching the pelvic floor simultaneously. So what will happen? Let us see. From the discussion of the mechanism of normal labor, we have understood that touching the pelvic floor and then forward rotation is a very important component of normal labor, mechanism of normal labor. So in that case, when the occiput, starts rotation through 3/8 of a circle, but in the meantime, after 1/8 of a rotation, the synciput also touches the pelvic floor. So there is no leading pole, and therefore no one moves anywhere. In the meantime, contractions are continuing, and dilatation of the cervix happens. Full dilatation is there. After 1 hour, we call this condition as a deep transverse arrest. Deep transverse arrest is self-explanatory in its words. Deep means the head is engaged. That means head is deep inside the pelvis. The sagittal suture is in the transverse disposition. So transverse is there. And the arrest means any mechanism of arrest demand that there is no progress of the fetal head, no descent of the fetal head, because of the factors that I mentioned just now, no progress of the fetal head, even after 1 hour of full cervical dilatation and a good uterine contraction. So this phenomenon is called the deep transverse arrest, and the students will often face this question on deep transverse arrest in viva voce or even in theory questions. So this is a very important thing, the devolution of deep transverse arrest, how it happens. I'll come to the management part later. Now take up the second situation. This was the first situation of abnormality, barring those 90% cases where the spontaneous full rotation occurs. The first instance is that the occiput and the synciput are in the transverse disposition, the sagittal suture in the transverse diameter, head is deeply engaged on the pelvic floor, but it cannot rotate, cannot come down. Remember, if it cannot rotate, it will not come down. That is the mechanism of normal labor. We have already discussed that. So therefore, this condition, after 1 hour, we call it deep transverse arrest. Now let us take the second situation, where the deflection is slightly degree more. There is moderate degree of deflection. That means occiput and sinciput are both on the same plane from the very beginning. That means there is no leading pole from the very beginning. So what will happen here? If the pelvis allows this, I mean the inlet allows this kind of disposition of the head will go down, but there will be no further flexion or deflection, because both the occiput and the sinciput are trying to stretch the pelvic cavity, pelvic floor, and therefore they remain stagnant on the pelvic floor. That means at the level of the ischial spine. So this is called the oblique occipito-posterior arrest by following the same mechanism as after 1 hour of complete uterine contraction and complete cervical dilatation, it remains in the oblique position. That means the right oblique position. This is called the oblique occipito-posterior arrest. So now, just now we have described two types of arrest that can happen. One is the deep transverse arrest, another is the oblique occipito-posterior arrest. Now let us take the third position, which is a bit rare, but it can happen. Here, the occiput is at the higher position than the sinciput. So now the sinciput becomes the leading pole. So sinciput, since it is the leading pole, the occiput is not the leading pole. Now the sinciput tries to rotate through 1/8 of a circle. The most convenient direction is this. That means anteriorly the sinciput goes under the symphysis pubis. This is called the persistent occipito-posterior. If it stays like that, it becomes persistent occipito-posterior arrest or occipito-sacral arrest. That means here the sinciput becomes because of the severe degree of deflection, almost short of extension, just short of face presentation, it is just rotating through 1/8 of a circle anteriorly, the shortest possible distance, because now the occiput cannot rotate. It is not the leading pole. It hasn't touched the pelvic floor. The sinciput has touched the pelvic floor. Okay, so therefore now the sinciput for the first time, it rotates through anteriorly 1/8 of a circle or 45 degree to bring the sinciput under the symphysis pubis. So this is an abnormal position leading to the persistent occipito-posterior and the arrest we have already defined, and it becomes the persistent occipito-posterior arrest or the occipito-sacral arrest. So there are three kinds of arrests that can happen in those 10% of cases where this long internal rotation does not happen. In the pelvis, long internal rotation is very, very welcome thing, but it is possible only when you have favorable circumstances, like you have a reasonably adequate pelvis, like you have good uterine contraction, and the fetal attitude is well. Okay, and not much of deflection is there. So these are three eventualities that may happen in cases of non-rotation or malrotation. Malrotation means sinciput moving anteriorly. That is called malrotation. So let us now discuss the management propositions in these conditions. Although they are rare, roughly 10% of cases we will find that. But remember, management of these conditions will demand availability of a senior obstetrician around. Unless and until a senior person is there, you will not be able to judge adequately whether the baby will be delivered vaginally or not. And there will be a rise in the increasing number of cesarean sections. Delivery of baby by the cesarean, that's the safest option. Well, we can come to the cesarean section option later, but in the management part. But there are possibilities where you can correct this malrotation or non-rotation manually or by forceps and then deliver it vaginally. That is possible. So that is the purpose that when we promote vaginal delivery in the era when the rising cesarean section rate is there, we need to see all attempts should be there in order to expedite vaginal delivery of a laboring woman. Now, what are the possibilities that we can have? As I said already, the presence of a senior obstetrician around is very, very important, because he or she will judge the possibility of a safe vaginal delivery. That is the most important issue. You need to assess the pelvis. Now, obviously, the pelvis won't be very adequate, very roomy, because otherwise the occipito-posterior won't have happened. Occiput would have gone anteriorly. So the very position of the occipito-posterior suggests that the pelvis is not adequate, usually. Or other factors maybe, that means the uterine contraction is not there, not enough. Now, when the leading poles of the head, they do not touch the pelvic floor properly or differentially, these uterine contraction will not be also generated. So naturally, you need to find out which factor is operative in which case. In cases where the uterine inertia is the cause of this occipital posterior, not the defective pelvic architecture, then what will happen? A simple correction of the uterine contraction by oxytocin after your assessment will be enough. You have to wait and watch and assure the woman that yes, you are taking a longer time, but it is possible to have a vaginal delivery, safe vaginal delivery. Now, obviously, the incidence of instrumental vaginal delivery will increase in such cases because you need assistance in such cases. But you have to remember, or you have to find out which case you need the assistance and which case you just need to have wait and watch only. Let us see. So when the occipital posterior has been arrested like this, deep transverse arrest, something like this. Now reassess the condition, go back abdominally. You see the amount of liquor amnion that is there. That means whether the manipulation of the fetus is possible under the circumstances, you must have adequate amount of liquor amnion. And in cases where the rupture of membrane has been already there, it is already there. It is a phenomenon of second stage of labor, but remaining liquor in the abdomen is very, very important to assess. And that is to be done by a senior obstetrician because you need some manipulation of the fetal head. What do you do? This is the pelvis. This is the pelvis which you hold like this, and your right hand should be inserted inside the cavity, inside the passage with the 4 fingers. So, but this condition has to be done under general anesthesia. You cannot do it in the labor room. You have to shift the patient to OT, describe the anesthetist that this is a case of prolonged labor. I'm trying to correct the malposition of the fetal head. So kindly give anesthesia. The general anesthesia is preferred. So you will go inside and with the help of your right hand, this is the occipital posterior position which has given rise to the transverse position of the fetal head. And when that is happening, then you have to have a shearing movement of the fetal head by your right hand, by this way. This is called the shearing movement. Okay. Tangentially, you should put the shearing pressure on the occiput. Remember, you cannot do anything here because that will not help it. But it has to be like this, and it has to be like this. So whenever there is it has to be like this. So whenever you can put the tangential pressure or the shearing pressure on the fetal head, gradually you can see that you can generate the rotation of the fetal head. This is called the manual rotation of the fetal head, like this. It may be possible to do only half rotation. Rest of the rotation can be done by spontaneously by uterine contraction, and this way the occiput can come anteriorly. So this is called manual rotation. Now, in cases where you can do the complete rotation, the role of the left hand is very, very important. Left hand is on the abdomen. You need to catch hold of the shoulder of the baby and try to rotate it and try to bring it to the midline. So these 2 hands together an experienced obstetrician will be able to do in cases where pelvis is not the factor, but where the uterine contraction was the factor. And then you rotate the fetal shoulder to the midline, and by shearing movement, the occiput has to be brought to the midline. At least we must try. After putting it in the midline, don't take out your hand and take the left blade of the forceps and introduce it like this from below. So the head is like this. The head is like this, and you have to put the left blade of the forceps like this, and then you can bring out the baby by a forceps delivery. So that's why I said that the instrumental delivery rate is increased in cases of occipital posterior. Now there are special techniques for the forceps delivery as well. I will just give a brief description because that's not the topic of discussion. Forceps delivery is not the topic today, but you must remember that the occiput, although it has come anteriorly, but it is behaving like the by the posterior is rotating into anterior. You may not need forceps also, because if the contractions are adequate, just addition of oxytocin is enough. But in cases of persistent occipital posterior, you need forceps rotation and forceps application and delivery. So in cases where occiput is being placed posteriorly, how we will deliver by forceps? Let us see. When the occiput is posteriorly, persistent occipital posterior like this, that means like this. So you put the forceps blade like this, and the pull of the forceps will be something different. You see, here the root of the nose has to be hinged under the symphysis pubis. In cases of occipital posterior to coming to anterior delivery. Anterior delivery coming is not possible. So now the root of the nose is hinging under the symphysis pubis. Now the forceps comes from below, from here. So the forceps catches hold of the head like this. And then the direction of the pull, I'll show you like this. Direction of the pull of the forceps should be like something like this. The direction of the pull, the forceps blade, direction of the pull should be downwards and horizontal. Downwards means this direction, and horizontal means towards you, straight towards you, in order to make the nasion, a root of the nose of the fetus, stuck under the symphysis pubis. That's the first job. The first movement of the forceps blade is that it brings down the head and puts the nasion or the root of the nose under the symphysis pubis. That is the first job done. Then after you realize that yes, the root of the nose is hinging under the symphysis pubis. How do you realize that? You can palpate the nose here and there is no further movement of the fetal head. So that is the point of, that is a feature of diagnosis of root of the nose has been hinged under the symphysis pubis. This is called face to pubis delivery by forceps. Then you stand up and change the grip of the forceps, and now the pull should be upwards and forward. That means if this is the fetal mother's head, this side, upwards means this direction and forwards means this direction. Resultant force is like this. So upwards and forwards movement. So these are the technical aspects of the forceps delivery which one experienced obstetrician must take into account. And it is like the taking off of the flight. So upwards and forwards movement will release the fetal head, but it will not be able to deliver the face. So after you have seen that the delivery of the vertex, occiput, vertex have been delivered, then you will relax once again and then come backwards pull posteriorly for release of the root of the nose from the symphysis pubis. So you see, special skill is necessary in order to deliver an occipitosacral arrest or persistent occipito-posterior arrest leading to face to pubis delivery. So this is one thing which is very crucial in case you want to deliver it by forceps. Okay. Alternatively, much better option will be if you have a ventouse or vacuum extraction, which will autocorrect the rotation and flexion at the same time simultaneously, and then you can have a good vaginal delivery, and the lady also feels well that I have delivered vaginally. Forceps is discouraged these days, not much, and not much practically used these days, but ventouse is a very good option. Finally, there is something called forceps rotation and forceps delivery. You can do the rotation and also correction of syncretism and malrotation by forceps, which is known as the key lens forceps. Now, personally speaking, I have never used key lens for last 10 years. I have last used key lens forceps 10 years ago. I haven't used that. So I can't tell you, but actually, I also not encourage the key lens forceps delivery because it is traumatizing for the baby. It is also traumatizing for the mother. So I think that key lens forceps is not very favored these days. Instead, cesarean section will be much safer in most of the circumstances. In cases where eventually the fetus dies, we used to be taught in our student days that a craniotomy should be done for the delivery of the fetal head. Nowadays, I think many obstetricians will think twice before doing a craniotomy because of many issues, litigation, other issues, and also the presence of the accompaniment during the labor. It is not very safe option to go for craniotomy. But with the progress of days, scientific achievements, antibiotic delivery, etc., anesthesia, I think that cesarean section is much safer under the presently than others. So that is the way that there will be marginal increase in the cesarean section rate. We can't do anything about it. So assisted vaginal delivery, particularly ventouse, then operative vaginal delivery, cesarean section, etc., they will be able to be applied at different cases, varying from case to case, but all the decisions should be taken by a senior obstetrician. Now, things are really difficult when it happens at the dead of night when no senior person is around. I think that if this is the case, then I would teach my students that at least put your hand vaginally just to assess how much of space is there and whether the head can be lifted up because the surgeon may need assistance for delivering the fetal head abdominally also. Otherwise, cesarean section, abdominal head delivery also will be a problem. So I think that occipito-posterior position, it requires a skillful obstetric art. I have no idea about the Odon device, which is how much useful it will be in occipito-posterior, because I have not personally used that. Only in 1 or 2 workshops we have done the Odon delivery by with the help of Dr. Tim Draycott, but that is not enough. And Odon device is also not available currently because it's waiting the WHO trial. So I think that today the safer options will be, in most cases, as we see today, and 100% of cases are going for C-section. That should not be there. Some selection of the cases by a senior obstetrician, I think is legitimate to try vaginal delivery in cases of occipito-posterior. It is a difficult proposition, I know. So in summary, what did we see today? We see that the delivery of the fetal head is a complex process and much depends on this organ, that is the fetal head. When the deflection or is mild to severe, all the changes take place. So mild deflection, it eventually causes deep transverse arrest. Moderate degree deflection, it causes oblique occipito-posterior arrest, and severe deflection will cause the occipito-sacral arrest or persistent occipito-posterior arrest. You cannot do anything about this incidence of 10% incidence of abnormal outcomes in occipito-posterior. So identify those 10% cases. In these 10% of cases, identify each one the offending factor, whether it's uterine contraction, whether it's faulty pelvic architecture, whether it's something else. So if it is because of only deflection issue, you can try and correct it manually, manual rotation. But in all other cases, I think the cesarean section by an experienced obstetrician, decision by an obstetrician is very, very important and crucial. And remember, all these cases are cases of prolonged labor. So adequate IV fluid therapy and nutrition and support, mental support to the woman is extremely important. As I said, not only the patient, but also her relatives are waiting outside anxiously that why my woman is not being delivered up till now, why it is taking such a long time. So this delay has to be explained to the attending patient relative. Otherwise, they may think this is a case of medical negligence or something like that. So avoid that. So my students, I think, dear my students, always feel free to communicate freely with the woman, her accompanying person in labor, and also her relatives who are waiting outside. So I think with that, we can manage most of the cases of occipito-posterior, the malrotation and non-rotation of the fetal head. I think I'll end here because I think we have 2 more sessions. So thank you very much for your patient hearing. If you have any questions, kindly put it in the chat box, or you can ask directly also. We'll try to answer them. Thank you very much. Hafizul, I have finished. Hello.
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 Ashish sir.
Yes. I have finished. Hafizul.
Sir, we can start with the...
Yes. I can't see any question in the chat box.
Sir, we can start with the case discussion.
Okay, call the students then. Okay.
Dr. Meneka.
Dr. Menaka is here.
Dr. Meneka, please share your screen and introduce yourself and start presenting.
Okay.
Who are the students?
So myself, Dr. Menaka, second year postgraduate from Singalpeta Medical College, sir.
Okay. And along with you?
Shruti, sir, Dr. Shruti.
Dr. Shruti. Okay.
Good morning, sir. This is
Yes.
Dr.
Next.
I'd like to
Gayatri
request the
from...
faculty to take over this.
Yeah. Dr. Shruti, kindly start your video, please. Yeah. Okay. Dr. Shruti, I can see.
Yes.
Dr. Menaka, I can see.
Yes, sir.
Start your presentation. And the faculty, all the faculties are there.
Yes, sir. We are there, sir.
Okay.
Dr. Shruti, seat yourself so that we can see you. You are not visual. You are not seen here.
Yeah.
Yes.
Kindly
Come
share the
closer.
screen.
Come closer. Yes, good. Okay. Good morning, sir. This is Dr. S. Gayatri, second year postgraduate from Shengalpet Medical College Hospital, sir.
Okay. Yes. Share your screen and start the presentation, please.
Yes, sir. Yes, sir.
We are waiting for you.
Ma'am, you have to share your entire screen, ma'am.
Is there any problem in sharing the screen?
Yes, sir. Yes, I'm not able to share.
Admin, can you help her? Just go down, you'll see a blue button called share screen.
Yes,
Press on that. Is the presentation open on your desktop?
Yes, sir. Desktop only, sir.
Desktop, no?
You open the presentation.
Keep the presentation open. Okay.
Menaka, after clicking on the share button, you have to go and select on the PowerPoint screen.
Yes, sir.
Ma'am, first open your presentation in your device.
Menaka, open your presentation first, ma. Then you can start sharing the screen.
Okay, ma'am.
Ma'am, you can select from here also, ma'am.
Is the PowerPoint open? Dr. Menaka?
Yes, sir. It is open.
You just stop sharing. Now click on the share button. Now a lot of windows will pop-up will open. Of that pop-up, you select the PowerPoint pop-up.
Sir, is it visible now, sir?
Yeah, yes.
Now it is visible. Yeah.
Dr. Shruti, you are not visible. Your face is blurred.
Shruti, come closer now, ma'am. Come closer, ma'am. Come closer. Come closer.
Dr.
Otherwise, you can
Menaka,
remove that blur
you
background.
can go to videos. Near the video button, there is a upward sign. On that, there is an option called blur my background. You can remove that blur my background.
Shall we start, sir?
Yes, you start. Start, please. Start.
Okay, sir. So good morning to one and all, sir and madam, respected faculties and my colleagues. We are here to present a case on abnormal uterine bleeding. This is Dr. Menaka, Dr. Shruti and Dr. Gayatri from Shengalpet Medical College and Hospital. So regarding patient details, Name of the patient, Mrs. X, age 34 years, a housewife by profession, education 12th pass, socioeconomic status belonging to lower middle class socioeconomic status, who is a resident of Chengalpet. A 34-year-old Mrs. X, who is a primipara with previous normal vaginal delivery, has come with complaints of heavy menstrual bleeding for the past 8 months. History of presenting illness. Patient has complaints of heavy menstrual bleeding associated with spasmodic dysmenorrhea for the past 8 months. Her last menstrual period is on 24th of December 2024. Frequency of cycles is 30 days once with a duration of flow of 8 to 10 days. Regularity, she has regular cycles. The amount of flow is, she changes 6 to 8 pads per day. Patient also gives a history of passage of clots and there is dysmenorrhea present. So history of spasmodic dysmenorrhea starting from day 1 of menses and lasting for 3 days. It is not associated with any history of dyspareunia. No history of intermenstrual bleeding or postcoital bleeding. There is no history of lump or abdomen. No history of vaginal discharge. No history of any bladder bowel disturbances like urinary retention. No history of loss of weight or loss of appetite. No history of easy fatigability or breathlessness, lethargy or any swelling of lower limbs. There is no history of any bleeding gums, hematuria or any other bleeding manifestation. Coming to menstrual history, patient attained menarche at the age of 13 years. Her last menstrual period is on 24th of December 2024. Previously, the patient had regular cycles with a frequency 30 days once, duration of flow 4 to 5 days with no passage of clots, no dysmenorrhea. But for the last 8 months, she is having heavy menstrual bleeding. The cycles are 8 to 10 days of duration of bleeding with the frequency of 30 days. Passage of clots is present and the patient changes 6 to 8 pads per day and there is history of dysmenorrhea also. Coming to obstetric history, she's a para 1 live 1, a full term vaginal delivery, giving birth to a female baby of birth weight 2.8 kg 2 years ago. Marital history, she is married since 3 years. It's a non-consanguineous marriage. Coming to past medical and surgical history, she is not a known case of diabetes, systemic hypertension, thyroid, tuberculosis, bronchial asthma, heart diseases, epilepsy, chronic kidney diseases, or any liver diseases. There is no history of any previous surgeries or any blood transfusion. Coming to personal history, the patient gives a normal bladder and bowel habits, normal appetite and food intake, normal sleep pattern. There is no history of any drug abuse or smoking or alcoholic. There is no known case of allergies. Coming to family history, there is no similar complaints in the family. There is no history of any breast or ovarian or endometrial pathologies running in the family. There is no history of any bleeding disorders in the family, and there is no history of any thyroid disorders also in the family. Coming to treatment history, the patient gives a history of taking tablet tranexamic acid, 500 mg tablets TDS for every cycle for the past 3 months from a nearby hospital. But she also gives a history that symptoms has not yet resolved even after medication. Examination by Dr. Menaka is.
Myself, Dr. Menaka, I will be presenting examination part. Coming to examination, after getting consent from the patient, the examination was done. On examination, patient was conscious and oriented to time, place, and person. Afebrile, hydration is good, and moderately built and moderately nourished. Mild pallor is present, no pedal edema, no jaundice, no cyanosis, no clubbing, and no lymphadenopathy. Bilateral wrist examination was normal, thyroid examination was normal, spine examination is normal. Height of the patient is 152 centimeter and the weight of the patient is 60 kg and her BMI is 25.9. Vitals of the patient, BP is 110/70 millimeter of mercury, temperature is normal and her pulse rate is 86 per minute. Systemic examination, respiratory system, normal vesicular sounds are heard, no aided sounds, and cardiovascular system, S1, S2 heard, no murmur. Coming to abdominal examination, on inspection, abdomen is flat, not distended, all quadrants move equally with the respiration, umbilicus is in midline, no scar or visible pulsation or dilated veins, hernial orifices are free. Coming to palpation, abdomen is soft, not tense and not tender, no hepatosplenomegaly. A midline mass which corresponds to 16 weeks of gravid uterus size is seen in suprapubic region. All borders are felt except the lower border which is not palpable. Smooth surface and regularly defined borders, firm in consistency, not tender, and side-to-side mobility is present. Percussion. Dull knot over the mass is seen. No shifting dullness or full thread. Auscultation, normal vowel sounds are heard. Local examination of genitalia, external genitalia appears normal. Per speculum examination, cervix and vagina appears healthy. No bleeding or discharge at the time of examination. Bimanual pelvic examination, cervix is pointing downwards and uterus is anteverted, uniformly enlarged to 16 weeks of size. Movement of cervix transmitted to the mass and not tender and mobile. No adnexal mass circled and fornix is free. Coming to summary of the case, 34-year-old Mr. 6, trainee para with a previous normal one vaginal delivery, having regular cycles, came with the complaints of heavy menstrual bleeding for the past 8 months, associated with the dysmenorrhea. She has midline mass corresponding to 16 weeks size of gravid uterus, which is mobile, well-defined border, and found to be arises from the uterus, probably a case of AUBL leiomyoma.
Okay. So, the faculties, Dr. Shruti, Dr. Shobha Gudi is there. Dr. Shobha, are you there? And Dr. Manika Agarwal, are you there, madam?
Yes, I am there. Can I start with the questions?
Yeah. Please start.
Okay, students, well presented. Now, first of all, I would like to know what is your differential diagnosis?
Differential diagnosis are, number one is pregnancy. Second one is could be adenomyosis or could be hematometra or pyometraman.
Don't tell me the bookish differential diagnosis of leiomyoma. Tell me the differential diagnosis in this particular case.
Can be full bladder, ma'am.
What?
Full bladder.
Full bladder, I believe you must have asked the patient to empty her bladder before you examined her.
Examine. Empty.
This is what we think about in the books these are given. In your patient, you know you have excluded full bladder. In your patient, you know that pregnancy is not a differential. So apart from leiomyoma, in this patient, you have any other differential or you don't?
Adenomyosis, no.
It may be possible. Okay, let's start with AUBL. Let me know the points in favor of your diagnosis.
I'm so sorry, I'm just disturbing you like that. But can we just go back to the history once? Like, can we just ask them ki why did they ask all those negative histories? Just to elaborate ki what all are you ruling out by asking all that negative history?
Yeah.
You can just share the screen once more.
Yes, ma'am.
Go back to the history. Huh? Yeah, so you have taken a lot of, when you call heavy menstrual bleeding, you started like that, she is having. So how do you say that it is heavy menstrual bleeding? Why did you say it was heavy?
Heavy menstrual bleeding.
There is increase in the regularity, frequency, and amount, volume of the that she is having, ma'am.
You did not measure the volume now. So how did you say it was heavy? When you're asking the patient, how do you know it is heavy?
History of changing pads.
Number of pads, ma'am.
Is there a definition for that?
Increased in the.
So what does the definition say regarding heavy menstrual bleeding, the latest? When do you say it is heavy? So it is the patient's perception. And if she says it is heavy from the previous cycles, you have to take it as heavy. Okay. If it is affecting her daily routine, it is affecting her mental status. Okay. Her routine activity, then it will be called as heavy menstrual bleeding. Okay. If she is becoming anemic because of that. Or she's changing 2 or 3 pads in every 2 or 3 hours. If she is saying like that, then you have to take it on her, whatever she's saying, and you have to term it as heavy menstrual bleeding. Okay, fine. Then why did you ask all these negative histories?
History of intermenstrual bleeding
can be seen in endometrial polyp, ma'am.
Okay. So it can cause heavy menstrual bleeding and it can also cause intermenstrual bleeding, polyp. What else can cause intermenstrual bleeding?
Submucosal fibroid, ma'am.
Okay, very good. What about postcoital bleeding?
Cervical CA, ma'am.
And anything else more common than that?
Cervicitis, ma'am.
Cervicitis. Cervicitis can also lead to abnormal bleeding as well as postcoital bleeding. And lump abdomen, why?
To
Keep
rule out
keep on answering. Like lump,
Okay.
you asked for this.
History of asking lump for any CMM malignancy.
Malignancy at 34 years. Okay. What else? More common than malignancy? Lump. Why did you ask for lump?
What is your diagnosis, dears?
You yourself wrote the diagnosis. Provisional.
Glioma,
So, will it present as lump sometimes when the patient
Yes,
can't
sometimes
perceive?
it will present.
So lump. You should have also asked about heaviness. Many a times they don't feel lump.
Okay.
Okay, it is missed, but they will have heaviness in the lower abdomen.
See, usually when it refers to per abdomen examination, we use the word mass rather than lump. Mass per abdomen.
Okay.
So mass,
mass.
Yeah, it is an abdominal, pelvic abdominal mass, abdominal pelvic mass, or only pelvic abdominal mass. Like that, we use the term mass. Lump is more used in relation to the breast. In general, lump, it is like that. Though grammatically it may mean the same, but even then, mass is the term used for abdomen. So you are saying no mass palpable. That will be better to say no mass palpable rather than lump. Okay. Any other features you looked for? Yeah, carry on with the slides. Yes.
Why did you take negative history? Jaldi bata do. Matlab, you can just hurry in this. Vaginal discharge for what?
Vaginal discharge for PID or TB, ma'am, and submucosal fibroid with ulceration with 50% of the discharge.
Very good. So dysmenorrhea also? It could be associated with what kind of fibroids?
Dysmenorrhea.
All fibroids or certain kind of fibroids are more related to spasmodic dysmenorrhea?
Submucosal, ma'am.
Yeah. So spasmodic can be associated with that. But congestive dysmenorrheas can also be there with the fibroids?
Ma'am, because of increased vascularity and congestion, congestive can be also present, ma'am.
Okay, very good, very good. Okay.
And
You can
cancer can be
without dysmenorrhea also.
Correct.
Could you have a case? Do you usually have fibroids with dysmenorrhea or without dysmenorrhea? And if there is dysmenorrhea with fibroid, what are the causes? We can have fibroids without pain in abdomen, without dysmenorrhea?
Yes, without.
In which cases of fibroid we have dysmenorrhea?
It could be torsion or degeneration, ma'am.
Yes, torsion, degeneration, infection, and submucosal fibroid.
Yeah, see, this is something I was also wanting to ask you, that the associated symptoms, you must also be able to quickly kind of recollect what are the associated pathologies commonly found with fibroids.
Yes, ma'am.
So that you should keep in mind. Yeah.
So what all is associated with fibroids? That's why you're asking about
can be adrenal degeneration, ma'am.
Adenomyosis, ma'am, and endometrial hyperplasia. It could be.
No, what can cause pain? That you must tell. You said degeneration. You said submucous fibroid. Fine.
Why could there be
These are related to fibroid, but associated pathologies. What are the associated pathologies?
Hyperestrogenic state, ma'am.
You asked about dyspareunia also, right?
Why? Increased vascularity of the uterus.
No. There is another associated condition which is commonly seen with fibroid, which can also cause dyspareunia, dysmenorrhea. What is that condition? Many times endometriosis can be associated with hyperestrogenia, which will mimic all these features. Fine. Okay. Any other question?
Okay, then you can now come back to the original question that you have made a diagnosis of AUBL. Kindly specify the point.
Just one more question
of your diagnosis.
Which kind of fibroids cause urinary retention?
Anterior cervical fibroid.
Anterior and cervical fibroids. Cervical fibroids are associated with retention or some other problem?
Increased frequency of urination is associated with anterior fibroids, ma'am. In case of posterior fibroid, there will be urinary retention, ma'am.
Very good. Why? Why is posterior fibroid associated with urinary retention?
It compresses the bladder neck, so it will be causing.
Yeah, so basically it causes retroversion of the uterus. It will fall back and it will cause stretching of the urethra over it, and it can cause retention because of that. Okay, and it can also cause bowel disturbances like constipation. If it is a posterior fibroid. Cervical fibroids are associated with what?
Cervical fibroids are associated with descending
Ureteric
discharge, ma'am.
problems, like it can cause hydronephrosis.
Broad
Yeah, so that is what the problem is. You
Yeah,
have loss of
see,
urine loss.
in general, when you're dealing with fibroids, you need to have menstrual symptoms, history, you need to have symptoms related to pain, you need to have symptoms related to pressure, and you need to have symptoms related to fertility. Okay, so whether there is subfertility or infertility like that, because these are actually also the management pathways. When you come to management, because asymptomatic fibroids we essentially don't manage only, right? It's only when these symptoms come, then we have to. So your history also should be directed to that. The
But till
pressure
now, your
symptoms
history
will
actually,
include all this, all the urinary problems, pressure on the upper urinary tract, and on the bowel, and sometimes there will be there will be obstruction of the lymphatics, obstruction of the venous return, etc. And the heaviness of the abdomen and the mass effect in very large fibroids, right? Yeah. Somebody was saying something. Yeah.
ma'am, I was
Yeah.
saying, because from your history alone, if we look at this right now, we are asking about AUVL because you have already given us a diagnosis. But from your history, we cannot say it is fibroid alone, right? So you should have also ruled out other endocrinological problems. You did not ask about any thyroid related problems. Did you ask about that?
Yeah, ma'am. Regarding the weight loss.
Weight loss is not a feature. It is only a feature of what? What is more common? Is it hyperthyroidism or hypothyroidism?
Hyperthyroid, that will be weight loss, ma'am.
Weight loss with hypothyroidism.
Hyper, ma'am.
So which is more common? What thyroid disorder is more common?
Hypothyroidism.
Hypothyroidism. And hypothyroidism is usually associated with HMB. Right? So you should have taken a negative history about that also. Hai na? So that is missing in your history. And there's no lump. So right now we should not be focusing on fibroid. We should be looking for any other cause of HMB in your history. Fine? Carry on.
Yeah, any other negative? She has taken no history of bleeding gums, hematuria, other bleeding manifestations. She has written
There are
that.
bleeding disorders,
Yeah.
ma'am.
Yeah. Can you name one or two bleeding disorders which can present as HMB?
Ma'am, von Willebrand
Von
disease,
Willebrand disease, ma'am.
thrombocytopenias.
One is von Willebrand.
Factor VIII deficiency, ma'am.
ma'am.
I can't hear you properly. Don't talk together, please.
One
One is
at a time.
Factor VIII deficiency, von Willebrand disease, ma'am.
you already said that. Please don't repeat the answers. Next. Another one.
Thrombocytopenias, ma'am.
ITP, yes.
ITP.
Idiopathic thrombocytopenic purpura. And the third one, sometimes HMBs are first manifestation of leukemias, blood dyscrasias. They're the first manifestation. Do you want to rule out any iatrogenic cause of HMB? Has it come in your presentation? Any iatrogenic cause of HMB? Can you name a few iatrogenic causes?
Intrauterine contraceptive devices, ma'am.
Okay. Anything else?
Did you take any medication history?
Antiplatelet medication that we have started for the patient for some other reason.
Yeah, you must give what medication. You can't just say
what
antiplatelet.
Name the medications. Name the drugs. That is how you'll ask the patient, no?
Warfarin, aspirin, ma'am.
Aspirin, ma'am.
Okay, aspirin, ecospirin, yes, aspirin, yes.
Warfarin.
Warfarin, okay. Clopidogrel. Sometimes statins also cause excessive bleeding. All right. So you must have all this in mind, because sometimes it is drug related also.
Okay, ma'am.
So other drugs which cause thrombocytopenia can indirectly cause HMB also. So sometimes, diclofenac and NSAIDs, sometimes they cause platelet suppression temporarily. So you must always take medication history as well. And for all you know, sometimes there is irregular intake of emergency contraceptive pill, off and on, or if they are prescribed some other medication, other hormones they may be taking irregularly. So take medication history always. Okay, next please.
Shobha, I agree that the medication history should be more elaborate. And in the history part, they have mentioned only past usage of tranexamic acid. Nothing else is there. And it is unusual then in a country studded with so much of gynecologists, nobody has prescribed hormones in this case for last 8 months. She has been suffering for 8 months. So any hormonal therapy, if that is not given in last 8 months, then I think that you should mention here that no hormone therapy was given to this woman.
Yeah, that is a relevant negative history, correct.
Even in your OBS history, you could have asked about any PPH and all. Okay, that could also tell you indirectly about any bleeding tendency that she could have developed later on. Okay, as an adult. So, because she is having HMB. Okay, continue.
So you can now talk about why did you come to a diagnosis of AUBL, points in favor?
Abdominal mass is a 16 weeks, ma'am. Firm inconsistency.
So you have no points in history to...
History of complaints of menorrhagia, ma'am, for the past 8 months.
You don't use menorrhagia these days, so you should avoid using that term when answering. Okay?
Okay.
Don't use menorrhagia. Okay?
Yes, okay.
So you say it is HMB.
Okay.
And it is regular or irregular?
Regular, ma'am.
Regular. Regular.
Regular
Does it go in favor of fibroids? Or whatever your diagnosis was?
Yes, ma'am. 34 years old with the complaints of heavy menstrual bleeding.
Yeah.
The regular cycles for
Your
before
husband.
8 months.
Order
For the
my-
past 8 months, she is giving heavy menstrual
It's
bleeding.
almost
ma'am,
1 o'clock.
With the passage of clots and increase in
Later.
frequency and the duration of the cycles, ma'am, and changing her pads 6 to 8 pad. On examinations, mild
No, you just enumerate the points which favor your diagnosis of fibroid. So
Okay.
first, she is
34 years
34
old.
years reproductive age.
34-year-old, which is a very
34
common age group, ma'am.
Okay, what else? The
History
points
of
in
heavy
favor
menstrual
on the
bleeding.
basis of history and examination. You can point out why did you keep the diagnosis of AUBL as your first?
Yes, ma'am.
And she also gives the history of HMB with dysmenorrhea, ma'am.
Okay, what else? What about parity? What is the relation of parity with fibroid?
Nulli parity will more prone for fibroid, ma'am.
She's parity. She's only para 1
She's
L1.
Para
para
1, 3, 1, L1.
And one more important thing in your history itself, you did not mention she's already 34, one child, 4 years old, whether she's trying for conception, something like that, whether she's, we'll know whether she's infertile or any other. This has not been mentioned here at all. Okay, this has to be mentioned. Fine. What else? So parity, decreased parity, one child is there. That is a protective factor. But decreased parity is again a risk factor. Nulli parity or decreased parity. What else? Then her symptoms, you said symptoms. Any other risk factor she has for AUBL?
She attained menarche at 13 years of age, ma'am. So early menarche is also a risk factor, ma'am.
13 is not an early menarche.
It's normal.
Early menarche will be less than 10 years.
Less than 10.
Okay, this is okay. This is a good age. 13 years is okay. Okay,
So
what
you
else on
now
examination?
come to your
Examination,
examination
what
findings.
findings?
Examination, ma'am, a mass of corresponding to 16 week size.
No, what about the BMI? What is her BMI?
BMI is 25.9.
What classification? BMI according to classification, she'll be in what category?
Category 3, ma'am.
Category 3 of what? What is the normal BMI in Asian
It should
population?
be less than 23, ma'am.
So she's 25.9. What?
Overweight. She'll come with
25.9.
She's overweight. These days the classification is changing. Now they have removed that overweight thing. It's all about obesity now. Okay. So you have to check that. Okay. And you should know what class of obesity she'll fall in.
Okay.
Okay. How do you know that the 16 weeks mass is a fibroid and not adenomyosis? Can it be an ovarian mass?
Yes, ma'am. It can be differentiated from the groove sign, ma'am.
Abdominally, how
What
can
is?
you differentiate? For the
Is it
abdominal,
only the
what are
group sign or
findings?
something else?
In case of adenomyosis, the size of the uterus is less than 12 weeks, ma'am, not more than 12 week size.
Acha. What else? You have written that it is smooth surface and regular borders,
Yeah,
not irregular. So
In
I would
adenomyosis,
want
the
to get
uterus will be
adenomyosis.
enlarged uniformly at globular in size.
Okay, and it is mobile, है ना? That is another good
Side to
sign.
side mobility is present.
Why can't it be an ovarian mass? A
No,
big
because the lower border is not
will not be
palpable.
felt in the
So that will
pelvis.
tell us- lower border is not palpable, so that will tell us it arises from
Okay,
uterus and
very
not
good.
from
Lower margin is not felt. What else? What about the consistency?
Firm and consistent.
It's
ma'am.
firm. What about the
ovarian
ovarian
mass
mass?
is
It will be
cystic.
okay.
Cystic,
So
ma'am.
which ovarian masses will present with HMB or AUB? It could be an ovarian mass. Who knows? Could be a solid mass.
Endometriotic, ma'am.
Stomach tumors, which is going to secrete estrogen, ma'am.
Like granulosa cell tumor, etc. Okay. But since it is a firm mass arising from pelvis, lower border is not felt, will go more in favor of an uterine pathology and not an ovarian. Okay.
So
What is this groove sign? What is groove sign? What is groove sign? You just mentioned groove sign.
Yeah, ma'am. The mass can be by bimanual palpation. Both hands can meet in between this uterus and the mass, ma'am. It is possible to meet. It is ovarian origin, ma'am. If it is
Acha.
absent, then it is fibroid, ma'am.
What else? What other things you do while doing a pervaginal examination, which can tell you that it is a uterine mass?
Transmitted mobility, ma'am.
Huh?
Transmitted mobility. Ma'am.
Yes, yes. What happens if it is an ovarian mass? The movement might not be.
Might be false, not seen, ma'am.
Not be. But big masses usually they also get transmitted to the cervix, so it is not 100% thing. Okay. Big masses, it is difficult to make out by only the mobility thing. Okay, if it is getting transmitted to the cervix or not.
So
Fine.
how will you like to confirm your diagnosis?
By examination.
After examination, I'm now talking about investigations in this case, which you will like to undertake.
Ultrasound, ma'am.
What is the basic investigations, ma'am? Complete blood count. Hello.
Yes, please elaborate and enumerate the investigations you will like to do in this particular patient.
I will do the basic investigation,
complete blood
complete blood count, ma'am, and RFT, LFT, and electrolytes, ma'am. And I will do the ultrasound, ma'am.
Then going for the non-invasive methods like abdomen USG, ma'am.
Okay. Have you talked about hemoglobin?
Yes, no, I told complete
hemogram with HB.
Okay, fine. So in after hemoglobin and ultrasound and other blood tests, would you like to do endometrial biopsy in this case? And if so, what is your intent behind it? Will you like to do endometrial biopsy in this particular patient?
Since there is increased estrogen, if there is going to be associated hyperplasia, endometrial hyperplasia, then we need to treat accordingly, ma'am. So we can also combine it with an endometrial biopsy.
How do you know it is endometrial hyperplasia? Endometrial hyperplasia is a pathological, histopathological diagnosis. You cannot make it on ultrasound. You can only see endometrial.
Doing endometrial sampling, ma'am.
I'm telling the reason why should we take endometrial biopsy, ma'am?
So you said endometrial hyperplasia, है ना? So how will you know there is endometrial hyperplasia? It will only be after biopsy, right?
Yes, ma'am. Yes.
And it is not 100% associated with fibroids. It is not always associated, right, with endometrial hyperplasia.
Yes.
So what will you see on ultrasound that will tell you? You said na you will do an ultrasound. You will do a TVS or a TS?
Both, ma'am.
Huh? Both?
I will do both.
How do you decide what to do? In which
The
case?
mass is palpable per abdomen. We have to do
This is
transabdominal
going
because
from
in
this is going from EB to ultrasound. Let us go one by one.
One by
Discuss
one.
the image. Discuss imaging first. Which case do you want to do abdominal scan? Because see, whenever you send to imaging, any which way the sonologist will never do only TVS. First, they do by default they do abdominal, because when you tell them also do only TVS, they will do abdominal. It is their protocol or checkpoint, etc. No checklist. That's how they go about it. So it's okay to say to be particular about TVS. You will get ask for an abdominopelvic scan. It's okay in a mass, but TVS will give you more information. So 1 minute. So you must be able to tell what extra information you get in transvaginal. That's what your teacher is trying to ask you. Okay. What extra information you get about fibroids? Yeah.
Transvaginal, it can be, we can do the fibroid mapping, ma'am.
Okay. So you want to see the location of the fibroid.
Location of the fibroid.
Whether it is actually fibroid or not. That is your provisional diagnosis. You want to confirm it by ultrasound. So you want to see it is fibroid only or not? How do you know it is fibroid? How do you see it on ultrasound?
Ma'am, in transabdominal, it can be homogeneous mass with hypoechoic area, ma'am.
Okay.
So be similar to that of the myometrium. If in case of submucosal fibroid, to differentiate from polyp, we have to go for saline infusion sonography, ma'am.
Okay, we'll talk about that later. So you want to see where is the location of the fibroid, how it looks, you have already said. And then you have to see the number. Number is important or not? Your plan of management will change according to that. Location, number, what else?
Vascularity, ma'am. Peripheral vascularity.
Okay, that will confirm that it's a fibroid. What else? What do you want to see on ultrasound now? Endometrium? You just said endometrial hyperplasia.
Endometrium, you have to see the endometrium.
So what do you want to see in endometrium? You want to see the
endometrial thickness.
Thickness and the junction also.
Okay.
Endomyometrial junction is always important. You cannot just see the endometrial thickness alone. You have to talk about the junction.
Yes, ma'am.
All right. When do you call it as a thickened endometrium in a reproductive age group woman like this?
It is eating more than 12 mm.
So normally for thickness, you should always measure it in the post-menstrual phase. If it is still thick, like more than 8 mm is also considered thick in immediate post-menstrual phase. All right. But more than 12 mm is anyways called as thickened endometrium.
Okay. Yeah. But having said that, you should also know that there is no scientific backing for cutoffs in reproductive age group for endometrial thickness. Unlike the postmenopausal, where we say 4 millimeter is the cutoff for pathology. Here, there is no cutoff for. So, endometrium which is less than that, 10 mm, doesn't mean that there is no endometrial pathology. But a very thick endometrium, definitely. So now that is one thing. Then the adnexa also needs to be seen in minute detail, because small ovarian tumors can get missed on transabdominal. Always see on the transvaginal also. And also, I think presence of adenomyosis along with fibroid is important. Okay, because that is also these are extremely important points of information when you are considering expectant or conservative or non-surgical line of management, and very important when fertility issues are there. So you should always be very clever about fibroid imaging. You must know everything about it. I highly recommend all my students to accompany patients to the ultrasound room, and then with every patient preferably. And if they are admitted and going for ultrasound, it's better to go along with them and see the transvaginal sonography there. And obstetric cases also I encourage. But this fibroid mapping is of particular importance. Today's point of discussion. If I can discuss the endometrial biopsy in the next 1 minute or two, I just wanted you to be alert about, in spite of a endometrium looking, not suspicious on ultrasound, which are the cases where mandatorily you will do an endometrial biopsy before formulating the line of treatment. That you must be very, very sure about.
Yeah, I think if the students have a list of that indications,
correct,
we must put forward a note of caution to the cases where we go for endometrial biopsy. In one such case, for instance, you can cause more harm than good by doing an endometrial biopsy in the traditional way. How? In submucous myoma, when you do the endometrial biopsy via curettage, say, you will expose the base of the myoma, you will poke into the myoma because you're doing it blindly, isn't it?
Yes, sir.
So what will happen? The bleeding will continue because of the loss of the pseudocapsule, which is protectively surrounding the myoma. And then you start bleeding, and then the patient, I have seen patient ending up in hysterectomy, emergency hysterectomy. So a note of caution for this. Ultrasound measurement is okay, but as Shobha said, there is no cutoff which have been established so far, 8 mm or 12 mm, in the reproductive age group. The reason being, the progesterone level is so highly fluctuating during the reproductive period no value is of significance unless and until you find some atypia or other changes in the histopathology. Okay, so I think that you should be doubly cautious about endometrial biopsy unless and until you get a positive indication, risk factor indication like family history of cancer, etc., obesity. In those cases only, you should go for a gentle curettage by a very experienced person, preferably under some guidance. Okay, so be very careful about doing endometrial sampling or endometrial biopsy, particularly blind endometrial biopsy in cases with submucous myoma. That's I wanted to point out that. And it's not very helpful also from the management point of view. Okay, so remember it's an estrogen dependent condition, not only estrogen, it's also progesterone dependent condition. Don't gain much by the doing unless and until there are, I think here the presence of myoma, more than that, you need another risk factors or other risk factors to justify your dilatation and curettage or rather curettage alone. Okay, so this is not a first line of investigation in cases of big myoma like this case.
There are certain cases where you like to do, as Madam said, where it is mandatory. Maybe heavy menstrual bleeding is accompanied with irregular menses. So their endometrial biopsy is mandatory. Yes, there are two schools of thought. In every case, it is not required, which you should be able to deliberate and understand.
So there is an age cutoff also. She's a young patient. So usually they say more than 45 only with irregular bleeding is that. So, but younger patients, if they are a known case of PCOS, they are obese. Even in them, there are high risk of hyperplasias and cancers. So in those, again, this age wala factor will not work. Okay? In there, you have to have a lower threshold for doing a endometrial sampling. So as sir said, there could be a trauma. So what instrument do you use to biopsy or do a endometrial sampling?
People,
Pipple. Okay, Pipple is much safer. But if Pipple is not available because it could be slightly costly, like you have to buy it from outside. What else can you use? Simple, very fine. Or Carmen's cannula can also be used. Okay, or suction catheter attached to a syringe that can also be used. All right. So all these are non-traumatic ones which can be used for sampling. Okay, ma'am, you can ask.
In other words, you should always be very careful about doing a curettage, and our decision must be taken by a senior gynecologist, justifying all the points. Just blindly, routinely, you cannot go for DNC in all cases.
Yeah, I think what Ashishta is trying to say is, especially in cases of submucous myoma, bleeding, yes, and also there can be an nidus of infection which is introduced. And I think these cases, see, one thing you have to understand, which is different in submucous myoma, is there is some element of necrosis also. And that tissue can get very easily infected. And the cases of, pyomyometra kind of situation, or, myometritis, endometritis kind of situation can develop. Fibroid can get complicated with infection also. Plus, bleeding is also a real risk because submucous myoma can have a lot of superficial vascularity. So this is a word of caution. But otherwise, there are specific indications which have been discussed. At the cost of repetition, women who have PCOS, metabolic syndrome, obesity, history of chronic anovulation, infertility, subfertility in the past, and in middle age, they are presenting with fibroid and bleeding, one should always suspect whether there is any endometrial pathology. There is a very rare eventuality of tuberculosis also, especially may not be in a frank fibroid like this, but many times there are chronic endometritis, which could be tubercular endometritis. So that also you should keep in mind, apart from the hyperplasia and carcinoma spectrum.
So one specific indications of curettage, or rather sampling of the endometrium, is a very valid question, because every student will be asked about the question of this practice is still valid in most of the part of the countries, and therefore the indication of curettage or sampling, I think, is a very important question. You should know it, and you should be very specific about the answer.
Yes, very rightly said. I just wanted to bring the discussion with the students on the point of MRI, because I think Dr. Nandini has also put forward, you should know when MRI is indicated in these situations, in fibroid.
Yes, Menka. Shruti?
Inconclusive of the diagnosis, ma'am.
What do you mean by inconclusive?
Like whether it is where the fibroid is located, we can't diagnose it with the USG. And for fibroid mapping, we can go for MRI.
Okay, fibroid mapping with what in mind?
In relation to some
When is
treatment,
fibroid mapping important?
in which treatment?
Huh.
All
Maybe
medical,
which condition
surgical
with fibroid
management.
mapping?
Surgical management.
With surgical management.
Which surgical?
Myomectomy.
Yes, so that is
Oh,
the
in young
basic.
patients, huh? When you are trying to do a conservative surgery, or we are not very clear how many number of, where is the location, what all procedure you might have to do, in what way you are going to remove those myomas. Because many a times you are doing minimally invasive. So palpation is is difficult in those. So you need to know the location of the myomas in that condition. So MRI is one thing.
Yeah, one
What
thing
about leiomyosarcomas?
in short,
One minute.
what
Sorry,
happens
I'm
is-
going like a little.
Okay, no. Just
There
I
is
wanted to
sarcomatous changes also. If there is sarcomatous degeneration, we have to go for MRI, ma'am.
Then a diffusion weighted imaging on MRI is a better sensitive thing. If there's sudden increase in the size of fibroid, something like that is a history. There is a history. Then you can even go for MRI.
And one should always understand that sometimes MRI and CT images may be suspicious. So in young patients, you cannot take a final call based on only CT or MRI pictures or images. And one thing which I also wanted to point out, which students may at times find, sometimes the radiologist will give an impression after pointing out the findings that there is increased endometrial thickness. But a gynecologist should take it also as has been already said, there is no cutoff in a reproductive age group. So their impressions may be misleading, and we should view it in the light of the knowledge that we read in our books, which eventually says that there is no particular cutoff in our gynecological books. So sometimes radiologists give an impression which we cannot corroborate with the knowledge which we as gynecologists read in our own literature. So this I want to bring to the notice, because many a times we find it's a case of fibroid on ultrasound or anything. And when you operate the patient, sometimes it is different. So you have to keep a lot of things in mind.
Yeah, I distinctly remember going during my endoscopy training, and our trainer himself could not locate the fibroid which was seen on ultrasound. So he just did bilateral hypogastric artery ligation to reduce the, bleeding, and then it was a midlife case. So he just came out because he could not see anything. It is possible that a small focus of adenomyosis was mistakenly reported. We can't say. So whenever there is a doubt and whenever conservative treatment is being offered to the woman, especially conservative surgery, maybe adenomyomectomy or a myomectomy, then probably MRI is important, just to be very sure. And also, when you have some doubt about the nature of the extent, sometimes in cervical fibroids, large cervical fibroids, MRI is useful to find out which part of the cervix it's involving more, and how far into the broad ligament it is, and whether it is affecting any nearby tissues. But by and large, imaging is not as important as it is kind of thought of. It's clinical evaluation which helps you more, but you must know the exact benefit of that test which you are asking and what you are going to do with the result. So just writing of the investigations is not. You should know what are you looking for, and then how is it going to help you in management. So just doing the imaging is not of use. You should
actually,
be able. Yeah.
Shobha, I think you are trying to hit the point, and I also agree with you that imaging is such subject that in our gynecological training of the postgraduates, we do not give much importance, and there is a severe incoordination running between the sonologist and the gynecologist.
Exactly.
One example is endometrial hyperplasia or endometrial thickness kind of thing, that is by the sonologist. And I suppose that the MRI, the students have the idea or the perception that MRI is one stage ahead investigation of ultrasound, which it is not. I
It is
think
not.
you should take every investigation or every investigating tools very wisely. For instance, today it rarely happens that a fibroid, an ultrasound will not be able to diagnose the extent of the myoma or the so-called mapping. And for mapping, only the MRI is not indicated as such, because many ultrasound are much superior than MRI images. So MRI is once again like the indications of the endometrial sampling is a specific question, and the student should learn it properly. Yes, diagnostic confusion is one, determination treatment is one, although ambiguous cases by the ultrasound one, because many of the cases I have found that the sonologist writes in the end suggested clinical correlation.
And sometimes, sir, they also write suggested MRI. So I
Yeah.
feel who takes the call, the radiologist or the gynecologist, that further investigation is required. So that is also another issue.
I think we should take in our light. If they write whatever they write, there is no war between the sonologist and the gynecologist. The lesser the war, the better it is for us, for mankind. And also that we should assess the case from our perspective, because they do not know many perspectives of the gynecology and obstetrics, and also we do not understand many perspectives of the sonology. So I think a balanced decision has to be taken, but the students, in the meantime, for passing examination, they need to know all these indications of MRI specifically, like indications of imaging. Indications of endometrial sampling specifically. So they should know all these things specifically. Just now, at the present moment, most of the students are of the opinion that the MRI is just one step ahead, CT and MRI one step ahead. So you go for serially go for ultrasound, CT scan, MRI. That is not the case.
Okay,
I hope that was made clear. Yeah. We'll go ahead with the management probably.
Yes, that's what I was thinking. How will you counsel the patients regarding various treatment options for this patient? And she might also ask you after you tell her the options, which is the best. So let's first start with the options which are possible in this patient, which you will suggest to her, counselor.
Go with the medical management, ma'am.
Okay, please carry on. You will not tell her in one line, that what are the medical management. Kindly elaborate it.
What will you tell the
antifibrinolytic tranexamic acid, ma'am, first to control the bleeding.
That is just a temporary treatment if she came to you during bleeding. Please elaborate on your treatment. What medical management, for how many months, what is the dose, what may be the success rate? How will you counsel the patient?
I will give our counsel to the patient for 6 months for medical management. If it's not controlled, I will proceed to surgical management, ma'am.
What medical management, my dear? Some medicines. Which medicine will you like to give?
I will give tranexamic acid 1 to 2 grams.
Both can be given.
You will give tranexamic acid for 6 months and then decide.
Hormonal treatment has to be started, ma'am. It can be OCPs, ma'am. Estrogen and progesterone combined pills or progesterone.
In present era, you will like to give OCPs in a patient of fibroid as a definitive management from medical point of view?
How will it help?
Better drugs which are available?
Other drugs, ma'am?
Yes, please elaborate.
Other drugs will be GnRH agonist and antagonist, ma'am. It will be leuprolide and goserelin and nafarelin and triptolurine, ma'am. We have to give goserelin 3.6 mg monthly subcutaneous injection, ma'am, for up to 6 months, ma'am.
Okay, anything else?
Triptolurine, we have to give 3.7 mg IM injection, monthly injection for 6 months, ma'am. Nafarelin should be given in the form of nasal spray, 200 mg per day. One spray in the one nostril in the morning, another spray in the evening in the another nostril, ma'am.
So
we have to give anti-progesterone.
Yeah, I think you are just enumerating the list which you have kind of.
Yeah, you should not. This is your patient. What all problems she has. You have to enumerate the problems and you have to start the treatment according to the problem she has. What is the main
line
problem?
one, even in medical management, there is first line management, second line management, like that.
Absolutely.
You cannot jump to the highest one and enumerate it as one of the options. You can't do that. You have to begin with the tranexamic acid, etc. And then you have to kind of see the response. Only if there is no response, because for all you know, she may be okay. And the other thing is you should be very clear in your mind what kind of therapy you are going to offer her. You will tell her the options of what? Medical management, surgical management, in surgical, conservative management, definitive management. Like that, what are you going to offer the patient first? And what are your reasons? Because in this
patient is
patient, I
already.
feel already having 16-week size fibroid, right?
Yes, ma'am.
If
She has
you give
already
medical,
received tranexamic acid. You already said. 3
already.
months she has already
She's
received.
already received tranexamic acid
She
without.
If the dose is not adequate, what is the dose, maximum dose that you should have given anyone to have effect? She was given 500 mg TDS, right?
Yes, ma'am.
So what is the dosage? Maximum, how much can you give? You should know all
2
that.
grams.
Huh?
2 grams, ma'am.
2 grams?
2
2
grams
grams
per
is
day.
enough? Huh?
2
From
grams per
1
day.
grams TDS can be given.
Yeah, 1.3 grams TDS. That is the maximum dose you can give to anyone. So she has not received, chalo, theek hai, she is not responding, at least you know that. So you don't want to waste any more time on that. You can increase the dose of Trenexa so that you can think about any other options that you can offer her. You are talking about GnRH antagonist and all. How long can you give it?
Ma'am, we can
Will it
start
help
her on
her? How long can you give it,
progesterone pills like norepinephrine, ma'am. Or
But you are not looking at the whole picture. Apart from her HMB, she is also a para 1L1. She is already 34. So she might be wanting a future fertility or conception. So all that has to be taken into consideration. Okay, how long can you give GnRH agonist or antagonist? Will it
6
help
months.
her?
No.
Whatever medical management you'll be giving with regards to hormones, it will hamper her fertility. She'll not be able to conceive with that. No, you should have that in mind. Okay?
Can I just know, I'm sorry, at that particular time my audio was not working. What is this patient's ops history in terms of the para 1? How old
Para
is the
1
child?
Y1. Para
How
1
old
Y1.
how old is the child?
2 years old, ma'am.
Huh?
2 years old, ma'am.
2 years old. Okay. So this case is definitely somebody where you have to offer her conservative management, and you have to see whether, if at all surgery is recommended, a myomectomy can be offered. And as far as possible, if possible, you must delay that also, unless there is a concern about fertility. So first thing you must tell us, what is the reproductive intent of this woman? What does she need in terms of reproductive intent? Does she need contraception also? Does she want to conceive now? Because 24 months is the minimum requirement for spacing by Government of India. In private practice, we recommend 3 years plus, but her age is also 34,
34
right?
years.
Huh?
34.
Yeah, 34. So you have to discuss all that with the couple, because as time goes on, this fibroid may grow further, and then the chances of conception might decline also, right? So the reproductive intent of the couple has not come into the picture. For such a young couple, you have to tell us that first. That helps in management a lot. For you also to answer, it will be better. It's nice that you got a young case for presentation, but in exam, if you get a young patient with a benign gynec disorder, your viva is going to be a little tough only. So you have to tell us about the reproductive intent of the couple first.
Did you ask her? Is she looking forward to having another child?
Yes, ma'am, I asked.
Huh?
What was the
Yes,
answer?
ma'am.
She said yes or no.
Yes, ma'am. She said yes only, ma'am.
So now let us proceed with this in mind, that she wants another child. She wants her fertility to be retained, as she wishes for another child. And since she's 34 years, the kind of medical management we are giving will probably only compromise her desire to have another child, as rightly told by Dr. Shruti. So in this scenario, what option?
I will go with myomectomy.
And how will you counsel? Though there are some other options also, but even yes, myomectomy would be the best.
They have jumped from medical to surgical very quickly.
But how much time we have in mind, madam? She's 34.
5 minutes more.
Yeah, I know.
We have 5 minutes.
So it depends on what did you see on ultrasound? What kind of myoma did you see on ultrasound? It was a submucous myoma. It is impinging the endometrial cavity, which is causing her HMB. It will also hamper her infertility, maybe. Maybe not every case
No,
of submucous
submucous.
myoma can hamper the
In
fertility.
a submucous,
Not
if it is
necessary.
there, and if there is a setting for infertility, that means the couple has been trying, then definitely it is an indication for surgery.
Yeah, so it depends
Yes.
on what you saw on ultrasound or imaging. Your plan will be according to that. How many myomas and whether that is there. Then your decision to see what management you will go will be much easier. So you have to answer according to that. Given ultrasound, because your findings on examination, I can see that it is a regularly enlarged fibroid. So it could be an intramural becoming a submucous.
Intramural period, anterior wall fibroid.
Because it is not a irregular. Fine. So you should answer like that. If it is submucosal, then I will go for a definitive or conservative surgical management like myomectomy. Okay. But then you should know what FIGO classification of myoma what are the FIGO classifications? What myomas can be managed hysteroscopically or which can be managed by laparoscopy or by abdominal route. Okay, that all This is a big myoma, so probably not a hysteroscopic. So what are the options that you'll be giving? What are the pre-op preparations that you will do? What counseling you will do? All that you have to answer now.
What is the prerequisites you do?
Prerequisites, ma'am. I will give the counseling for hysterectomy. If any heavy bleeding, possibility of heavy bleeding, we will proceed with the hysterectomy, ma'am. Then I will arrange the blood products pre-operatively. And then I will counsel.
Menika, she's already anemic. You don't want to address that first? She's bleeding
I
also.
will correct with anemia correction before surgery, ma'am. I will do fibroid mapping before surgery.
And you also look at the partner.
Yes, before myomectomy, you have to check for the partner. The investigation of the partner has to be done. You have to rule out other causes of infertility as well. That has to go simultaneously. Okay, you do a major surgery and she is having some other problem. That will be a big, it will not be good. Okay, then. So you want to build her up, improve her hemoglobin, at least make her hemoglobin more than
10, ma'am.
10.
10 grams.
10 or 11, it should be at least more than that. Okay, then prerequisites. You said you will arrange blood, you will take consent for hysterectomy. What else? What all counseling you will do? Yes, what else? Just these two will not be enough, na? What else you will, what other counseling points you will add? What will you tell her? What about the chances of recurrence? What about the chances of...
Chances of recurrence is 50 to 30%, ma'am.
So you have to include that, You have to even tell her about the excessive hemorrhage that can happen intraoperatively.
Yes, ma'am.
The number of blood transfusion that she might require intraoperatively. Okay, then you have to discuss the route which you will be taking whether it will be a minimally invasive or abdominal, whatever route you are taking to remove that myoma. Fine. So all these should be the part of counseling. Dr. Manika, any other point you want to add?
I just wanted them to tell me merits and demerits of uterine artery embolization and fibroid and role of mifepristone, because these are the drugs which are now coming up and PGs should know. So can you just let me know what are the indications, contraindications, disadvantages of uterine artery embolization? Do you have a facility in your college?
Prefer a uterine artery embolization? It's a conservative method, definitely. But what about your patient?
Yes.
Her age is 34 years, but her obstetric score is P1 L1. So we should not proceed with the uterine artery embolization.
Why?
Because it can affect the fertility. Future fertility it can affect.
How?
What are the pregnancy complications with the uterine artery embolization?
Okay, I think we have to wind it up because time is now. We are coming to the end of the session, and Dr. Nalini Mishra is waiting. I think
Ashishta, I think Dr. Manika is the one who were asking if you can only give off the students the points for embolization, so as to just complete the discussion.
Yeah, I think I'll be more interested in discussing on misoprostol because
misoprostol, yeah, mifepristone.
Uterine artery embolization, it will cause premature ovarian failure, ma'am. The risk of
yes, there is a 5% risk. Even in the best of techniques, there's a 5% risk of ovarian failure due to accidental ovarian embolization. Correct.
Very good.
Mifepristone has yielded very good results. In fact, the safety profile is emerging to be better than the ulipristal acetate. Am I right, Dr. Manika? You were wanting to discuss this.
Yeah, just a word like 5 milligram or 25 milligram dosage can be used for 3 to 6 months in this particular patient. And
Till
uterine
the time hemoglobin
nebulization
can be
is not a
improved,
good concept.
it will
Because
cover
this
the
is what
bleeding
we
part.
use more
Yes.
commonly than talking about OCs, which is good for undergraduates. PGs, I think so. They must be right.
Yeah, they must be familiar with ulipristal acetate and they must be familiar with mifepristone. My only problem with mifepristone is whether 25 milligram is available freely now. I have found difficulty because traditionally we use 200. Yeah, correct. For IUD, for missed abortion, and also especially for MTPs, we use 200. But for this purpose, we need only 25 to start with. So this
that
formulation.
was the case previously, Shobha.
Okay.
But nowadays, I think mifepristone 25 is easily available.
ठीक है,
And I
अच्छा.
can talk about this.
Yes, ma'am. 10 milligrams is not available. Even studies have been done on lower doses like 10. Yeah, that is difficult to be.
So
Fine.
I think
25 is available.
Then I think we should wind up the discussion. Students have done well because this is a very, very huge topic. And there was a lot of firing. And I think there was a lot of firing.
Like the uterus, the
though
topic
it
is
is
also huge. Yes.
Yeah, it is huge. Only thing is myomectomy, which is expected management line in this case, probably was not discussed fully. But then that is the limitation of any scientific discussion, Ashish, that we can wind up and go ahead.
Correct.
Thank you for the opportunity. Thank you.
Thank you so much, all the faculty members, for the intense discussion. I must thank
you to the organizers and well done students.
Professor Manika
and
Agarwal.
Thank you for inviting me.
And Dr. Shobha Goody. Of course, the trio has attacked the students like anything, left, right, and center. And I think they have done well, reasonably well. Yes, improvement, there's always a scope of improvement in every possible interaction, clinical interaction. And like the sonologists say, suggested clinical correlation, we'd also like to say suggested more and more discussion in future. So we will do that from ICOG. It is a guaranteed option from us. And remember, all these discussions are available in the website. So students, please tell your colleagues, I mean, those who are working in the labor room silently, tell them that go to the ICOG website and find out all these discussions. It will be extremely useful. You can also add or contribute to it. So having said that, I also thank the students, Dr. Minaka and Dr. Shruti. I didn't quite understand the role of Dr. Gayatri, yes. But yes, all three of them have done wonderfully well. And once again, by thanking the faculty, I close this session. Thank you so much.
Thank you, sir.
Thank you.
Thank you.
I thank the ICOG and also all the faculties for guiding our students.
Thank the newly elected president and the chairperson of ICOG. They have given so much of importance to the PG students and PG teaching that they have increased the duration of this program by half an hour. Although it is impinging slightly on the lunch side, but I think that book of it learning अच्छा होता है. खाना खाने के बाद लोग सो जाते हैं. Thank you so much. Yes, I'd like to now invite Dr. Nalini Mishra now. Time to invite her. Nalini is very well known nowadays in India. Abhijit, are you there or I should introduce her?
Yeah.
Oh, your network is very, trembling, no?
Yes, sir. You please do, sir. You can introduce me.
Okay. So the time to invite a fresh topic, under a fresh perspective, fresh management option, Dr. Nalini Mishra. Dr. Nalini Mishra is a Dean and Professor of Ellen Medical College and JK Super Speciality Hospital, Bhopal, a very prominent part of India, and she's also a prominent gynecologist. She has shot to fame very recently, an ex-HOD Government Medical College of Chhattisgarh. And she has done justice to the last place, Chhattisgarh, and she has devised a balloon. And I must say that an innovation which has solved many problems of seeing the uterine drainage while the balloon is on. While we were struggling with the Foley's or multiple Foley's, and we couldn't find the drainage, and she came out with this option, and she came out with the innovation. So I'd like to welcome Dr. Nalini Mishra, Madam. You kindly describe us, or rather teach us, on the balloon tamponade for the management of PPH. It is now an accepted option of management by WHO FIGO. So I think that Dr. Nalini Mishra will start her presentation right now. Thank you so much, Dr. Nalini.
Thank you so much, Ashish sir. I am always a fan of yours, and I have been listening to the previous session, and it went really wonderfully well. I'm sorry about I am having a little severe cold. So should I share my screen first?
Yes.
And my huge thanks to ICOG and FOGSI sir, and for the kind words you said about me. It's really an honor to be coming from you. So should I share my screen?
Yes, please.
So please tell me many times my this doesn't work actually. Slide share, then I will go and share, and you see whether it is coming or not.
No.
Yes, ma'am, it's
Actually,
coming.
you open this thing, presentation on your desktop, and then share. It will be easy for you.
Okay, sir. So I have opened it, and then
now make it full screen.
I make it full screen. Okay.
Yes.
Is it coming, sir?
It is visible now. It is visible, and you
okay,
clearly
okay.
audible.
So is it visible? So I have to go to the beginning. I think it has opened in the end.
Correct.
Just I'll have to.
You can go to the slide sorter menu also, but you can go back like this.
So means it will be this thing. There are so many videos. I was worried.
Yeah, ma'am, you have to share your sound as well. If there is any video or sound
No,
in
there are no videos are not with sound. I will be giving my own sound, but the thing is that if I go like this, then shortly I'll be there. And while I'm coming to the first this thing slide, I just want to say that sir, my presentation is not limited to my CG balloon only, but I'll be showing a little this thing of my other one more innovation, which is many of us are using, that is CG drape also. That's a low cost drape which we can use for collection of the blood. So again, I welcome all the participants and esteemed faculties. And I know I'm standing between you and your lunch, so I'll try to finish it fast. But sir, anytime you say, and I'll quit. So we all know how important is the maternal death rate or impact on the health indices of our country. 25% of our maternal deaths are hemorrhage related, and the condition is really worse in low resource settings, which is the fact of life in our country. So one woman is dying every 2 minutes because of the pregnancy and childbirth. So this is really pathetic. So we have to, management of PPH, actually, it doesn't start in the, after she has PPH, it has to start from the very antenatal time. We have to prevent anemia. We have to do all the preparations, and we have to timely diagnose the bleeding, and we have to timely act whenever we are going to do the treatment. And everyone must be aware of the PPH care bundle of WHO. And of course, uterine balloon tamponade is one of the recommendation by almost every guideline of the world. And if it doesn't work, then only we go for surgical treatment, which is not available in 80% of the facilities in our country. So that makes the uterine balloon tamponade a more important this thing. So how do we define PPH? All the PG students are sitting here. So we all know, we have been mugging up, no? There is a qualitative definition, there is a quantitative definition. So quantitative is always like that, you half a liter after vaginal delivery, 1 liter in cesarean section, and God forbid if you have to go for obstetric hysterectomy, more than 1.5 liters. Or qualitatively, when you say whatever is the amount of, if she is already anemic, she may decompensate with even 300 ml. So any amount of postpartum bleeding which is affecting her adversely, her general condition is deteriorating because of any amount of bleeding in the immediate postpartum, or as the definition goes. So any amount of bleeding which is causing her vitals to become unstable is postpartum hemorrhage. Or even sometimes there is saying that whenever you feel that it is excessive and worrisome, that is PPH. So as postgraduates, I think they have to stick to first two quantitative and qualitative definitions. There are many risk factors, but Ashish sir will agree with me. It's always unpredictable. You never know. Gravida 4 will deliver nicely and there will be no problem. And a primary gravida may suddenly land up into PPH. You never know. So we have to be prepared all the time. So the key point is early detection of PPH. So how do you detect PPH early? Whenever you do, routinely we do visual estimation, and visual estimation is grossly inaccurate. They grossly underestimate the blood loss. So we have innovated one drape, and this is CG drape. We call it Chhattisgarh drape. So what is it? You just prepare it from a plastic apron. Actually, a plastic apron comes inside the delivery kit, which is supplied by the government, or we can buy it in the market. It costs around 15 rupees. So I'll just explain it with the help of this video. You can see that there is there is this. Can you listen to me? Hello?
Yes, we can listen to you. We can hear
You can listen to me. So what we do is this lower folded edge of the vertically folded this plastic apron are sealed using a plastic sealing device. This is a device which is generally available in the malls and all. Otherwise, you can order it online, and a very small device is also available, which costs around 175 rupees. So here to just do it fast, because we do it routinely in our labor room and sisters prepare it. So just seal the lower edge of the vertically folded plastic apron, and then just convert that portion into a cone by inserting your two hands inside. And this has become a cone. Then at the you take a pre-marked scale, and at the 8.5, 10 and 12 centimeter, you just put 350, 500 and 1 liter. So only these three marks. And then just fold it, spread it on that table birthing surface, and fold the cone under the buttocks of the woman who is delivering. So this is nicely folded, smooth and soft, and it gives woman a hygienic birthing surface. After she delivers, we have to tie the belts of the apron, which we tie on our back in the front, and the neck piece of the apron, which we have split into two. So we use it as a upper belt. So the two belts, they ensure siphoning of all the blood inside the cone only. Once she delivers, ask the woman to lift her buttocks a little and unfold the this cone. And just after the amniotic fluid is drawn, we open this cone, and you see all the blood is being collected now in this cone. So there is, just for the purpose of making it easier, we have just made 350, 500 and 1 liter this thing. So this is how we do this visual estimation of blood loss. Quantity, this is a volumetric assessment. To it, we have to add the gravimetric. So the difference of any pad or any sponges which is used which was when dry and when it was soaked with blood. So the difference in weight, 1 gram is equal to 1 ml. So suppose a gauze or any this thing pack was 80 grams before before you mopped the blood with it, and then after it is fully soaked, and then you weigh it, and it comes to around 120. So the difference is 40 grams. 40 grams is 40 ml. So suppose there are 3 such or 4 such packs, so the difference will be 160. And if if the blood volume in this drape is 350, to add to this volumetric component, you add the gravimetric component, that is around 160. So that becomes more than 500, 510. So it makes your diagnosis easy and in time. So it's important to make the diagnosis in time so that you start your treatment in time, because our women are already anemic. You can't delay the treatment. So you have to identify it in time. So once it is diagnosed, everybody must know what is the PPH care bundle. So there are two bundles in PPH care bundle. There is first response bundle, and if the woman doesn't respond to that, there is second response bundle. So the first response bundle is meant for any skilled birth attendant. It's not made for those who are delivering at home. If it is a skilled birth attendant, then this can be done. Otherwise, it is meant for facilities, primary health center onwards. And it is mainly for the PPH because of uterine atony. Because atony is the cause in 70 to 80% of the cases. And surgical, the recourse is excluded from this because it's not available in many this thing. And primarily this was meant to be used in low resource settings. So there are four basic components of the first response bundle. We remember it by this mnemonic of motive. So M is for massage, uterine massage. Ashish sir will agree with me. Whenever there is a delivery and there is sudden gush of bleeding, immediately the hand of an obstetrician should go to the suprapubic area. You see whether uterus is soft or is nicely hard or not, and whether it is there or not. Sometimes there is inversion and uterus may not be there at all, but most of the times uterus is there, but it is not as hard as a cricket ball as it should be. So start massaging. Don't leave the patient. You just be there. You start massaging and shout from there. Ask somebody to just raise an alarm, call whatever help you can muster. And then if the uterus is soft, you start with oxytocin drugs. Immediately go for tranexamic acid before it's too late. Because as you delay the injection of tranexamic acid, the effect reduces. So go for tranexamic acid and start isotonic crystalloid. Tranexamic acid, you have to give 1 gram over 10 minutes. So that is it. And oxytocin whole regime is available. And of course, the IV crystalloids. In this, ringer lactate is the first choice, followed by normal saline. So I remember once Ashish sir has made such a good this thing that who will do what. So this is inspired from your presentation, sir. Who is the team leader will keep massaging the uterus. The staff nurse or other doctor will start oxygen and IV drip and 2 functioning line before starting they'll take out the blood sample for investigation. Then the third one will they will check the placenta and catheterize the bladder. Fourth one will communicate with the relatives, will go for blood if necessary, and will monitor the patient. So this is how you manage your team, and you have to keep on doing regular drills for that. And then how much crystalloid? So preferably if you have a ringer lactate, start with ringer lactate, 500 of ringer lactate in first half an hour, followed by another 500 ml in the next hour. But in the meantime, if she is bleeding heavily, you have to go for hemostatic resuscitation. What is hemostatic resuscitation? You replace blood with blood. So, or you just achieve hemostasis within 1 hour. That is the golden hour. You have to have the hemostasis. So, this is some video that we have made for the initial steps of PPH. Here the CG drape is already in place, and this lady is bleeding, and the obstetrician is massaging and instructing the juniors, and they are just checking up the placenta. They'll be catheterizing as well, and she asked somebody to bring that PPH box is already prepared. This catheterization is done. As we all know, the full bladder is also one of the cause of atony. So this is done, and there is this PPH box. The PPH tray. PPH tray has to be kept in the door compartment of the fridge for between 4 to 8 degree this thing, and all the drugs should have the marking in bold letters, so that in emergency you are not struggling with identifying the drug. So, and then in the PPH box there should be one tray of instruments For in case of any traumatic PPH, you have to deal with, you have to go ahead with the suturing and all. So there should be long sponge holding forceps, 2 big speculums and enough other material. This tray can be autoclaved every 3rd day. And then there should be enough of big IV, this thing, gray or green cannulas, syringes, and IV sets, blood requisition forms, all filled except the name and the number of the IPD number of the patient. There should be enough IV fluids. There should be catheter, urosec, condom, and there should be blood collection vials. So everything should be prepared. You should be well prepared because you don't know in which case you are going to have this postpartum hemorrhage. So this way it is done. And then if she responds to your first response bundle, bladder is empty, clots are evacuated, you have checked that there are no tears. If the uterus is well contracted, you have to naturally look for the other causes of PPH, and trauma is the next common. And but placenta is complete, bladder is empty, but she is bleeding. So you have to escalate your treatment, and then you proceed to the WHO bundle 2, that is refractory bundle for refractory PPH. So first was the first response bundle, and this is the refractory PPH bundle. So a bleeding that is unresponsive to the initial treatment, it triggers an additional set of intervention. So what is that additional set? As I said, set, it's a bundle. Why we call it a bundle? Because we all know we used to read that story, na, कि when all the logs were kept together in a bundle, it was stronger. So here also WHO has made bundles. So first bundle was oxytocin, massage, then IV fluid and Trenexa. All had to be given together. Here also you have to implement or institute the bundle. So there are 2 compressions and 2 devices in that. So first, the 2 compressions are manual aortic compression or bimanual uterine compression. And it's not necessary that you wait till this time. Suppose there is so much suddenly heavy bleeding, you can immediately go for manual aortic compression while you are summoning help. But this actually by protocol it comes in refractory PPH bundle. So manual aortic compression and bimanual uterine compression. Suppose uterus is not responding to your external uterine massage, then we have to go for the bimanual uterine compression. We all know how do you do that. And then then the next is intrauterine balloon tamponade and non-pneumatic anti-shock garments. So these are 2 compressions and 2 devices in this refractory PPH bundle. Now, why tamponade? Because there have been systemic reviews. They studied the success rate of second line conservative management of PPH. Conservative whenever you are trying to save the uterus. So they went for uterine artery embolization. They compared this uterine artery embolization. They compared it with compression sutures, with devascularization, and with balloon tamponade. And the success rate was nearly the same. So because common sense prevails that whenever the intervention is least invasive and can be most rapidly applicable, so balloon tamponade fits this criteria. And when the success rate was same, they said that we have to go for tamponade first. And secondly, to be on the legally safe, it is advised, recommended by almost all the guidelines of the world, may it be WHO, FIGO, RCOG, Government of India, ACOG, everyone. So what exactly is the balloon tamponade? Basically, it's a balloon with some mechanism to inflate the balloon. So the deflated balloon is inserted through the cervix into the uterine cavity. We inflate the balloon, typically using saline and warm saline in winters, until the bleeding slows or stops. And it acts as a hemostatic cushion, and the bleeding stops. It can be removed 6 to 24 hours later. As simple as that. If the bleeding responds to this inflation of the balloon with saline and the bleeding is controlled, we call it a positive test. Means the balloon tamponade has been successful. If she continues to bleed in spite of inflation of the balloon inside the uterine cavity, we say that it is a negative test. So means we have to escalate our treatment and go for the next step of intervention. Here, a valid question will be how much amount should we consider before declaring that this is a negative test? How much inflation volume? So it's not clearly mentioned anywhere, but it's an arbitrary amount of 500 ml. So in the uterine cavity, if you inflate the balloon with 500 ml of saline and the bleeding doesn't stop, so leave the balloon there and then you prepare for the next step. And when you are ready with the next step, then only you remove the balloon if the hemostasis has not yet been achieved. The next question is, when do you go for uterine balloon tamponade? What is the correct time when you start? When you say that now this is refractory PPH and she is not responding to first line. So what is that? When? There are so many guidelines about that. Whenever the obstetric shock index is more than 1 and less than 1.5, this is about CMQCC, California Maternal Quality Care Corroborative. So what is, even FIGO says that it is very, very successful and success rate is nearly 100% if you place the UBT device before onset of advanced degree of shock. So what is this obstetric shock index? It is heart rate upon systolic BP. It's very, very simple. Simply ask anybody in the labor room, what is the heart rate of the patient? What is the systolic BP? So the normal is 0.7 to 0.9. In non-pregnant state, this is 0.5 to 0.7. So whenever the pulse rate crosses the systolic BP, suppose pulse rate is 110 and systolic BP is 96. So that means obstetric shock index is 110 upon 96, more than 1, nearly 1.1. If the obstetric shock index is more than 1, then probably she has lost more than 1 liter or more than 15% of her circulating blood volume. So you have to, and the first line management has already been in place, not responding to that, go for balloon tamponade before it advances to 1.5, before the obstetric shock index goes to 1.5. 1.5 means pulse rate is 1.5 times more than the diastolic blood pressure. So the best time is as soon as the obstetric shock index crosses 1 in case of ongoing hemorrhage not responding to initial management. Why obstetric shock index is so important? Because there is rationality about that. Because of the changes of pregnancy, before there is fall in the systolic blood pressure, heart rate rises to compensate for the blood loss. So this ratio is more important. It's not only the pulse and not the systolic blood pressure alone. It's the ratio of the two, which is very, very important to measure, and this is very easy also, and it doesn't need any sophisticated instrument also, so it can be used in all the low resource setting. So practically saying, whenever you feel that she is not responding to first line management, we have to go for tamponade. Now the third question, which one? Which tamponade do we go? There are ample number of choices available in big cities, not in small places. Even in big cities, all of these are not available. So this is every second matters, and this is Ilavi, and this is Bakri balloon, and this is conventional condom balloon tamponade, and this is our CG balloon. So many of them. There are uterine specific devices like this Bakri balloon, BT cath, and EBB. They all have a drainage channel. Then Ilavi and ASM, they do not have they are without the drainage port. So in low resource setting, since Dr. Begum Akhtar has invented, Dr. Akhtar in Bangladesh has invented this tamponade, that condom has been fixed to a catheter and with a suture material. That was very popular and saved many lives. So, but there are some issues with that. And the issue is that whenever we tie any suture material to tie the condom to the catheter, sometimes the knot is leak. So you have inserted the balloon inside and you are filling it and it is leaking. So patient is bleeding and it is leaking. So means it may be frustrating sometimes. If you tie it very tightly, the fluid won't go in. It has been so tight. So how to get the optimal tightness was a problem, and then we had to secure the lower end of the catheter also to prevent the inflation fluid from the inflation fluid to come out. So either we had to just put in a clamp or tie the lower end also, and or to put a knot. So whatever, there were certain problems. So we came up with this CG balloon, and I'm so thankful to Ashish sir for recognizing my little humble this thing. And sir, CG balloon can be prepared in advance, because you might have to just remember these steps. And so you can prepare in advance and you can just get it ETO'd. Get it ETO'd from your this thing, and you can keep it ready in your labor room or in your operation theater. So this can be done. And this was published by the FIGO House, Oxford publication, and by our own Jogi. And then FIGO, in the latest recommendation by the FIGO 2022, they also cited this CG balloon. How do we make it? So you need this thing, some Foley's catheter of, take a bigger size of Foley's catheter. If not 24, at least take 20 or 22 French, a condom, scissors, and 2 syringes of 10 to 20 ml each, and saline. So you can remember it in the alphabetical steps, A to F. So A, we'll begin with A. A is for air. Now you take the catheter and through the bulb inflation port, mind you, the bulb inflation port, inject the air, 10 ml air, take off the syringe, then take the inflated portion, wind it around your finger, and then you just perforate the bulb. The idea is to just, we have to replace the bulb of the Foley's catheter with a bigger bulb made of condom to increase the capacity. Then just cut it all around. Cut this perforated bulb of the Foley's circumferentially all around. Then put the upper flap upwards and the lower flap downwards. The idea is to expose the hole on the shaft in the area of the bulb. So now comes the B. So for B, making the bulb, roll the condom over the catheter, proximal 1/3 of the Foley's catheter. It should not buckle. And then comes the C. For C, you just cut 2 rings. 2 rings of 1 millimeter, just like our rubber bands, which we put in our hair to make the ponytail. So take small thin rings. Apply the first ring. You see, there is a neck in the upper portion of the area of the bulb. So put the first ring over there. It won't slip. You can see it should not occlude the hole in the area of the bulb. So this was the C, and then double application of the ring was the D. And then the second ring is applied in the lower portion, 1.5 or 1 centimeter away from the rim of the condom. Only do it twice. So that is double application. So A, B, C, and D. So A for air, B for bulb, C for cutting the rings, and D for double application. Now E is excision. Cut the in the middle of the urine drainage hole, and then you make in the middle, and then this creates a hole at the top. So now the hole of the Foley's catheter, which was draining the urine, is now exposed on the top. This hole will now be draining the blood, which is being shed inside the uterine cavity, or the ongoing blood loss. And the bulb of the Foley's, which was small, which you have replaced with a bigger bulb made of condom, will be inflated with the saline and will use will be used for tamponade. So now you see, you have prepared this. Now you put it in the, this is prepared, CG balloon is prepared. You put it in the betadine for 3-4 minutes. In the meantime, just you see, she has lost more than 1 liter of blood. Already OSI more than 1.1. Now expose the cervix with 2 big speculums. Then catch hold of the anterior lip of cervix with one sponge holding, catch hold of the posterior lip of cervix with another this thing. Take out the CG balloon from the betadine and just, why is it not running? I think there was some problem. One, you can cut one, this saline bottle like this, and this is exposed. I hope it should be running. So again, this is caught, and patient is put in nice lithotomy position, and then you have to take out that CG balloon, yes, from the betadine, and just put it inside your 2 fingers, and just it goes inside easily till the rim of the condom is just inside the cervical os, just at the level of the internal os. And then after this, we have to pack the vagina so that when you inflate the bulb, the tamponade or the balloon doesn't come out. Now, this is done because we will be seeing the ongoing blood loss at the drainage port. Now, we connect the urinary drainage port with the urosac, and that will, you can see the ongoing blood loss. And then through the bulb inflation port, we just inject the saline, warm saline in winter this season, and till you start feeling the resistance. And then the column in the urosac or column in the this drainage port will stop moving. So whenever there is, now it is, you can see this column has stopped moving. Whenever the bleeding is less than 1 ml per minute, you can consider it as a hemostasis. So here you can see the nicely inflated balloon inside the uterine cavity. And then we catheterize the patient. You put her on oxytocin drip, mark the margins of the uterus, give her an antibiotic, and put her on oxytocin drip for 6 to 8 hours. And then you can remove this. What happened? You can do the deflation 6 to 24 hours later. And how to deflate it? Anytime in the routine hours. So either you can take out the fluid through the bulb inflation port, or simply you can put a needle, put it in a kidney tray, go for rounds, and slowly the fluid drains. And by the time you come back in half an hour or so, just take out the pack from the vagina, and the balloon comes out. And if there is recurrence of bleeding, instead of taking out the pack, you can reinflate. But so far, I have never encountered any recurrence of bleeding. This is very simple and very easy and nearly successful all the times, 96 to 98% of the time. So this is how this deflated balloon and pack comes out, and it looks. So this is it. And but many of our colleagues, they argue, what is the need of a drainage port? I say that even Sir Bakri, who has invented this Bakri balloon, he even commented on this channel, YouTube, that it's an excellent solution for low resource setting. And unless we have a drainage port, how can we say that whether it is a positive tamponade test or a negative tamponade? And we have to prevent the hematometra. So ideal conduct of the tamponade test. And secondly, you feel confident that, okay, still the blood is coming in the drainage port, so we have to inflate further. And the blood has stopped, so we can stop at that volume. So we tend to inflate the CG balloon with comparatively lesser inflation volume than we would do in otherwise a conventional condom balloon tamponade. So less inflation, patient feels less pain, and you are very, very comfortable, you are really confident. Many of our students and colleagues, they say me ki it gives us confidence if we are able to see that ongoing bleeding, whether it is stopped or not. So that's it. And we don't have to put our that packing of the vagina for a later period, because otherwise, if we don't have a drainage port, we have to look the ongoing bleeding at the cervix, and we can't pack the vagina. Then there is chance of that expulsion of the balloon tamponade, which is inside the uterine cavity. As you start inflating, it tends to come out, but you can't pack the vagina because you have to see the bleeding at the cervix. If you pack the vagina, the bleeding has to soak through the yards of that gauze and before it becomes visible. So this is a very good solution of having a central drainage port. And as sir has rightly said that previously they used to do two at least Foley's catheters, so one for drainage and one for this thing. So sir, I have reduced the expense of one Foley's catheter. So negative tamponade test, this is a therapeutic tool as well. If the tamponade test is negative, we know that we have to just move on to the next management. So the management is not delayed. The whole idea of PPH management is to achieve hemostasis, maybe by any method, before she lands up into this thing, irreversible stage of shock or advanced degree of shock, from where you do whatever you do, there is point of no return. So we have to know that when we have to move on to surgical this thing. And if the tamponade test is negative, we have to escalate our treatment. So this is very, very actually commercial versus self-made. We are self-reliant. It is very, very cost effective as well. In one of the systemic this analysis, cost effective analysis was done, and they found that CG balloon was one of the most cost effective device. So it was done by ICOG. It is cheaper and hardly any contraindications, mainly allergy to latex, we don't know. And hardly any complication. They were in cases of previous curettage and previous uterine scar cases, 1 or 2. And so it was not sure. And they were not very serious also. So hardly any complications. Sir, I think there won't be time for me to show the sandwich surgery or something.
I don't think so, because we have a quiz which is.
So I think I'll skip this, sir, because otherwise I could have shown that sandwich surgery, which is nowadays very much in practice for placenta accreta. But anyway, sir, I think.
Can you run it quickly? The video
No,
only.
no, sir. I'll have to explain. So maybe next time, sir, we can keep it.
Maybe.
We can keep it for next time, sir. No problem.
Okay.
So I conclude that balloon tamponade for management of PPH is recommended by WHO, FIGO, FOGSI, everybody. It requires least expertise. It is available, can be prepared at the point of care. You are self-reliant. You don't have to look at others. किसी का मुंह नहीं देखने का है. You can make it yourself. No need of electricity. No need of buying any additional instrument. And it gives you so much confidence. So it is effective in 95% of the cases, can be used in many other circumstances as well. And this is the power of our Bharat. So we are proud to be Indian. Thank you so much, sir. Thank you. And thank you all the participants. I have been keeping you away from your lunch. Thank you so much.
Okay, thank you so much, Dr. Nalini. It was a wonderful demonstration of your own innovation. And you have made not only Chhattisgarh proud, but also made all of us proud.
Thank you, sir.
This is accepted as a, as a therapy in almost all the recommendations, as you correctly pointed out. And if you go, FOGSI and WHO all have accepted this thing. And it is so nice to see that it is working so well. I can share my own personal experience, just a bit of to act as a devil's advocate. I have seen I have difficulties in making the small this thing, the rings. and stretching them over the condom. Maybe because I'm not used to tying ponytail. That's the reason.
Sir, you have to make thin rings, thin ring.
Yeah.
Because the commonest mistake that everybody does
the
is
thick,
they
thick.
make
No, no.
thick rings.
No,
You make
I
thin
understand
rings,
that. I
thin
made
rings, and that
very,
then it can be done very
I
easy.
made very thin rings, and they are barely visible. But even then, I was struggling because.
So, sir, I have to come to your place sometime,
Yeah.
and we can
And
do
help
it
me tie
hands-on
this
together.
thing. Otherwise, we have included this in our
No, sometimes Ashish da, sometimes what happens is the make of the Foley's catheter.
Yes.
Make of the Foley's catheter is like that. It is a little, stiff. Most often it will be a soft make, but sometimes it's a little stiff and it's not very distensible. So that is why maybe.
Next time we'll import from Chhattisgarh.
No, sir. You do it from any this thing. It's really. Shobha ma'am, I was listening to your inputs and they were really so much helpful in last session, and I am always really.
Nalini, you presented very well, Nalini.
Very well.
And very soon, Dr. Ashita will accuse us of mutual complementary society.
No.
Nalini, your presentation was good. It's very updated also because you added fresh points. So I was listening to you.
She had a comprehensive outlook at the PPH management, which is also beneficial for the student.
Sir, I prepared it from the point of view of PGs actually.
Yeah.
It was my fortune that stalwarts like you and Shobha ma'am were listening to me. Means you gave me so much of this thing. It's really something for me. It's big thing.
I was just thinking that every time we must have some kind of a checklist which can be provided so that the labor room can keep all those things, and like the PPH tray. So
PPH box
in
I
light
showed,
of what
that's
you
where I
presented
showed.
today,
Yes.
So which they can keep it, and that should be replenished. कि कल रात में use हुआ, फिर आज रात को फिर चाहिए. In the middle of the night, you can't get everything. So every day
वही
they
मैंने
should
बोला
come
कि
and check.
मैंने बताया कि ट्रे भी आपको हर तीसरे दिन ऑटोक्लेव करानी है. If it is not used, you get it autoclave every third day.
No, I think that handing over time, those who are taking over the labor room, they should make sure that.
Yes.
Preparedness is the most important thing, and particularly with this equipment, I think we need to be kept prepared at least one set or maybe two sets at a time in the labor room. Continuously, that should be available. That's the suggestion.
Sir, वो बना के ETO करके you can keep.
ETO
Make it and get it ETO'd and keep it we keep one in OT and one in labor room. And sir, in cases of fibroid uterus, submucous fibroid, where the cavity is distorted, this works very well because it molds to the uterine cavity. It's soft thing.
Correct.
So means people gave me these inputs that it works very well in cases of submucous fibroid. Having PPH.
And PPH, yes.
Very well done. Thank you.
Where the cannula may cause some trauma. Yes.
Yeah. So I will close this discussion here.
Yes.
And we are going to hear from you very soon about the tampon, this sandwich therapy, sandwich surgical management and sandwich therapy.
Okay.
We're going to do that. We'll do it later. But in the meantime, I am keeping myself away from Dr. Archana Kumari. That is a great offense because he's waiting with all the quizzical questions,
अच्छा, ये quiz master आ गए हैं.
Okay. We have been waiting for the quiz.
Wow. The distance between the
brand new quiz master hai.
Thank you so much, Nalini ji, and thank you so much for the excellent demonstration of the technique. And it's very effective, and I have seen it practically in cases. It's really effective. I think that it should be useful, and the PGs must learn, and we'll ensure that it becomes a part of the exam system also very soon. Time to welcome our new chairperson quiz committee, Archana. Are you ready with your setup?
Good afternoon, everyone. At the outset, I would just like to thank ICOG chairperson, Dr. Parag Binewala sir, for including quiz committee in ICOG for the first time. And I think ICOG is the academic wing of FOGSI, and quiz is a very academic event for the PGs. So because we are already running short of time, I have Dr. Rajesh, the South Zone coordinator of quiz committee, as quiz master for today. And he has already shared the game pin for the Kahoot app for all the participants who are willing to join in the quiz. and the topic as already was displayed in the PDF file was AUB. So let us see who all are logging in. Over to you, Rajesh. Are you there?
Yes, madam.
Yes.
Yeah.
So the
So,
QR code is shared.
Sir, should I need to share that link to the audience as well?
Yeah, you have to share it to the audience because they will be participating.
They need to, download this.
Rajesh, can you just briefly tell them about how to log in, the participants?
Yes, you can either go to, you can use your camera and scan the QR code on the screen so that you can directly go to the game pin and you can enter the game by entering your name. Or you can go to kahoot.it, www.kahoot.it. There you can enter the game pin 429658, or you can have an app installed in your phone. If you already have an app installed in your phone, you can directly go to the app and enter the game pin. Whichever way you can join. The easiest way will
so
be
we
to
can
scan
see
the
many
QR
of the
code.
participants. As many of the participants are now logging in, we can see their nickname on the screen. So how many minutes we are going to wait for them to log in? Maybe 5 minutes, Rajesh?
Yes, madam. We'll wait other 2 to 3 minutes anyway. So
And
yes, madam.
Meanwhile, they are logging. I just wanted to thank Shobha madam and Nalini madam. I was listening to their inputs and of course the brilliant presentation by Nalini madam. And of course, without Ashish's humorous touch, this is always a good to have sir here. And sir is coming day after tomorrow, sir. You are coming to Ranchi, right? We are waiting for you.
Yes, I am coming. So what you just asking, what do you do if you have too many participants?
Sir, we can accommodate up to
100.
Rajesh, how many participants we can accommodate?
100 we can.
100.
200.
200. Yeah.
100, madam.
100. Okay.
Yeah.
So that depends upon the package, no?
Mm-hmm.
So Rajesh, how many questions we have? 20.
We have around 20 questions. We'll finish it off within 15 minutes. So it will be fastest fingers first. You not just answer the maximum questions only. You have to be with the maximum speed also. So that is how we'll have the best participant.
So the participants have to note that they have to press the answer as soon as possible because your scoreboard will move according to your timing also, not just the correct answer.
We are still having people logging in. We'll wait another minute and then we'll start.
So total, how many have logged in? 34.
Yeah.
So I think now we can start. We have almost...
Yeah. So it is 260.
35 participants. So I think we start the quiz, or we shall wait
I think
for
so.
more
I think
participants to join.
we
will
have
start.
understood more or less, so you can start now. And you have enough participants now, 34.
34, yeah.
We will not lock the queues. Those who are interested can still join. So the game pin, please note the game pin 429658. You can still join. So with the permission, Archana madam, starting the queues.
Yeah, Rajesh, please go ahead. Yeah.
Yes.
So as told by a wise man, quiz is always the best, one of the best methods of teaching. And to brush up what we have studied in AUB, in this FOGSI ICOG PG clinic. I thank President FOGSI ICOG, President FOGSI Sunita Madam, Parag Sir, Chairperson ICOG, Ashok Kumar Sir, Swarna Madam, Sarita Madam, and all the coordinators of ICOG, Ashish Sir, Ashok Kumar Sir. So we'll move to the cues. It will be on topic of abnormal uterine bleeding. And let's start. Everybody can be prepared for the typing your answer, clicking the answers. So our first question is, what is the true statement about chronic non-gestational AUB in reproductive years? Whether it is bleeding from the uterine corpus, whether it is present for 12 months, whether it's sufficient quantity. Yeah, many has gone with all are correct, but the correct answer is bleeding from the uterine corpus alone, because it is more than 6 months is considered as chronic non-gestational AUB. And it's not that sufficient quantity required immediate intervention is of acute AUB, not chronic AUB. Chronic AUB may not be sufficient enough to require any medical intervention. So only bleeding from uterine corpus is the correct answer. So we'll move on to our next question. We'll see who are leading. Dr. Richa is the one who is leading. And next question. Light flow is when menstrual blood loss is less than 5 ml, less than 15 ml, less than 30 ml, bleeding for 2 days only. So which is the correct latest definition for light flow? We know what is heavy flow, more than 80 ml, everybody will be knowing. So what is light flow? So light flow is less than 5 ml bleeding is considered as light flow. So 12 of you has got it correct. So Dr. Richa still leading. Our next question. So according to the latest FIGO, what are the correct terminologies for unscheduled bleeding when patient is on hormones, which is not a correct terminology, not applicable, none, present, random. So everybody should be thorough with the newest terminologies. All this menorrhagia, menometrrhagia, polymenorrhea, all has been squashed off. So what is the newest terminology? So when a patient is on unscheduled bleeding on hormones, we can call it as not applicable, none, or present. Random is for intermenstrual bleeding. So intermenstrual bleeding can be random or predictable or cyclical, and unscheduled bleeding is when the patient is not on any medication, you can say not applicable. When patient is on medication and there is no bleeding, you can say none. And if it is present, it is called bleeding present. So these are the terminologies. So to have a light on to the newer terminologies, this question was put. So all comes to palm coin about it's about AUB. So it was first published in which year? First published. So it was published in the year 2011 and later it was amended in the year 2018. So Aparna Shetty has come to the top. So according to FIGO, increased frequency of menstruation less than 24 days is termed as what? Whether it is menorrhagia, polymenorrhea, frequent cycles, or heavy menstrual bleeding. An increase in bleeding less than 24 days. Increased menstruation less than 24 days. So increased frequency. Previously it was called as polymenorrhea, and presently the newest terminology is frequent cycles. So all these menorrhagia, polymenorrhea, all these terminologies has been taken off. Now it is known as frequent cycles. So Aparna Shetty is still leading, closely followed by Dr. Richa. So what is the definition of regular cycles except? So all are definition of regular cycles except one definition. So what is it? Less than or equal to 9 days in a woman of 18 to 25 years, less than or equal to 7 days in a woman of 26 to 41 years, less than or equal to 5 days in a woman between 42 to 45 years, plus or minus 4 days from the usual cycle length. So which is not a correct terminology for regular cycles. So in between 18 to 25 years as well as 42 to 45 years, it is less than or equal to 9 days, and 26 to 41 years, it is less than or equal to 7 days, or as general, you can call it as plus or minus 4 days. So Mallikarjun has come up. So regularity, according to the 2018 revision by FIGO, it has been changed from previously it was shortest to longest variation up to 20 days. Now it is not in practice. So a variation of 7 to 9 days depending upon the age. So the early ages like 18 to 25 years and 42 to 45 years, we can have a time period of up to 9 days. And between the 26 to 41 years, less than 7 days is considered as normal. And for practical purposes, FIGO says you can take it as plus or minus 4 days from a normal cycle. So submucous myomas in palm coin. So the picture shows different submucous myomas. So the newest palm coin, which all forms the submucous myomas, whether it is 01, 012, 0123, 1 and 2. So for the PGs, again, the newest revision of the 2000, many are going still with the 2011 palm coin. Many textbooks says that, but 2018 it has been revised and it has specifically been told us type 3 myomas are now coming under submucous myomas. So previously it was 0, 1 and 2. Now it is 0, 1, 2 and 3 is also coming under the submucous myoma. So Needu has come up with that answer. So what is type 0 leiomyoma? It is whether it is all pedunculated subserosal myoma, whether it is all pedunculated submucous myoma, whether it is submucosal myoma with a diameter less than 10% of mean diameter, whether it is submucosal with less than 50% stalk diameter. So which is the definition of type 0 leiomyoma? Again, all pedunculated submucous myoma was previous definition. Now it should be not just any pedunculated myoma. The stalk diameter of the pedicle should be less than 10% of the mean diameter of the leiomyoma. Then only we can consider it as a type 0 leiomyoma. So the stalk diameter is now coming under the definition. So since it's a PG teaching program, I'm going with the latest FIGO guidelines and all. So then there is change. Seal has come up. Dr. Nandini has come up. So fan-shaped shadowing in ultrasound is considered as a diagnostic criteria of which condition, whether it is endometriosis, adenomyosis, polyp, or hyperplasia. Fan-shaped shadowing in ultrasound. So as you know, that the diagnostic criteria has been changed by for the AUB, and now this many of you got it correct. It is adenomyosis. So adenomyosis, now the diagnostic criteria comes as the Musa criteria, morphological uterus sonographic assessment criteria. So there are 8 criteria for adenomyosis as shown in the picture: myometrial cyst, hyperechoic islands, fan-shaped shadowing, echogenic subendometrial lines and buds, translational vascularity, and if present, irregular junctional zone and interrupted junctional zone are also coming under the diagnostic criteria. So this diagnostic criteria comes under the morphological uterus sonographic assessment criteria. So this is the adenomyosis is the correct answer. And coming to some classifications, AUBM includes all except endometrial carcinoma, leiomyosarcoma, ultrasound showing endometrial hyperplasia. All of these are coming under AUBM. So some has got confused with the endometrial hyperplasia. Atypical hyperplasia, when proven by histology, comes under AUBM. Ultrasound showing a thickened endometrium or hyperplasia doesn't come under AUBM. It has to be proven by pathological pathology. Then only it will come under AUBM. So the except is endometrial hyperplasia by ultrasound. So Mr. Neil has gone up. Dr. Richa is closely behind. So patient on warfarin has heavy menstrual bleeding. What is the diagnosis? AUBN, AUBI, AUBC, AUBE. Whether it is not classified, whether it is iatrogenic, whether it is coagulation, whether it is endometrial cause. So as you know, warfarin is an anticoagulant which is commonly used in heart disease patients. And when he has got it correct, it is iatrogenic. Previously, it was coming under AUBC. Now it has been any drug-induced heavy menstrual or abnormal uterine bleeding comes under AUB, iatrogenic. So Mallikarjun is coming up. Isthmosil comes under which AUB? Again, for theoretical purposes, whether it is not yet classified, whether it is AUBE, whether it is AUBI, whether it is not otherwise classified. So isthmosil previously was not included in any classification, and in 2018 correction, it was included and it comes under not otherwise classified. So that is correct answer. Many of you has got it correct. Dr. Richa is coming back up. We have 5 more questions left. Diagnostic matrix for AUB. So what is the correct, which is not a correct statement from the above picture. Fibroid in ultrasound or clinical examination may be present. No evidence of adenomyosis or malignancy. Coagulation assessment not available. Endometrial hyperplasia may be present. So which is the correct statement, which is not a correct statement. 3 of them are correct statements according to the matrix shown. Again, many of us got it wrong from the picture. The L was marked, so fibroid is present. So that is not the right answer. And adenomyosis or malignancy was put as into mark. So that means there is no evidence of adenomyosis or malignancy. And coagulation assessment was coming under the question mark. So it is not available. And hyperplasia is actually coming under M. So that was also not there. So the wrong statement is hyperplasia may be present. The E was doubtful. E means hemostatic problems of the endometrium. It is not the hyperplasia. So Dr. Richa still leading. So ovulatory status in abnormal uterine bleeding due to ovulatory dysfunction can be determined by irregular cycles, mid-luteal progesterone, secretory changes in histopathology, all of this. So which can determine the ovulatory status? How can you determine? So all of this is the correct statement. By history, irregular cycles may denote AUBO. And if by investigation, you can go with mid-luteal progesterone. The level of mid-luteal progesterone will give us an indication whether the ovulation has occurred or not. And secretory changes in HPR in the late premenstrual phase may also indicate the ovulation has not occurred. Not much changes. Regarding von Willebrand disease, the wrong statement is, so von Willebrand is an autosomal dominant, is the most common variant of von Willebrand disease. Autosomal recessive is the most severe form of coagulopathy. Autosomal dominant von Willebrand has 4 subtypes. Autosomal dominant has total deficiency of von Willebrand factor. So which is the wrong statement? So it's a little bit difficult question, but for you to know, autosomal dominant von Willebrand is more common. It's almost 85% of von Willebrand disease. And autosomal recessive is rare but more severe because it has a total deficiency of von Willebrand factor. So autosomal recessive is the one which is having total deficiency of von Willebrand factor, and hence it is the most severe form of coagulopathy. Autosomal dominant more common and has have 4 subtypes also. So NEET2 has come up to the first place. So we'll go to the next question. Hybrid fibroid with submucous fibroid more than 50% intramural and subserosal with less than 50% intramural is denoted as. So hybrid, most of the fibroids are hybrid. So whether it is LH1 to 4, LH1 to 5, LH2 to 5, LH2 to 6. So submucous more than 50% intramural comes under 2, and less than 50% intramural subserosal comes at 6. Many has gone with 5, but it is 6. So LH2 to 6 is the correct statement. And the point score, Rekha Rani has come up to the 3rd place. So we are coming to the rear end, and we have close fight for the 1st place. Median time of regression of atypical hyperplasia with medical treatment is. So in AUB-M, atypical hyperplasia, if you give medical treatment, what is the median time of regression? Whether it is 6 months, 7 to 9 months, 1 to 2 years, or 1 to 3 months. We know we can try medical management in atypical hyperplasia if the patient wants to conserve the uterus, and usually the median time of regression is around 7 to 9 months, and it is told that if more than 9 months there is no regression, actually there is no point in continuing the medical treatment. So that is the criteria. So 7 to 9 months is the median time. It may regress in 6 months, it may take up to 12 months, but usually 7 to 9 months. So Dr. Richa comes to the 1st place again. Faults about desmopressin is. So the desmopressin, whether it can be used IV or intranasally, whether it can be used as a prophylactic therapy, whether its effect lasts for 6 to 12 hours, whether it can cause decrease in von Willebrand factor and increase in factor VIII. So what is the false statement? So the false statement is it increases both von Willebrand and factor VIII. There is no decrease in von Willebrand. So desmopressin can be used in this type of condition of AUB-C. It can be used IV as well as intranasal, and can also use patients for prophylaxis of AUB when they are nearing the menstruation, 1st day of menstruation role. They can use it as a prophylactic therapy. It can last up to 6 to 12 hours also. But it acts by increasing the von Willebrand factor as well as factor VIII. So Dr. Richa still leading. We are going to the last question. PAEC. What is PAEC? Pre-malignant condition, reversible condition, associated with tamoxifen use, all are correct. So what is PAEC? It's a treatment-related condition. And if you know, the full form of PAEC is progesterone receptor associated endometrial changes. So it is associated with progesterone receptor antagonists like mifepristone or ulipristal. It's not associated with tamoxifen. It's a reversible condition, and it is not a pre-malignant condition. It's a benign condition. So the correct statement is reversible. All statements are not correct. So by that we comes to the end of our quiz. Once again, thank you ICOG, Parag sir, Ashish sir, and my chairperson Archana Kumari madam for this opportunity. We'll go to the winners.
So can we have the scoreboard?
So the third, yes.
Yeah, podium.
So Dr. Mallika Arjun is 3rd place, Dr. Neetu at 2nd place, and with 7,753 points, Dr. Richa has come to the 1st place. So congratulations to the winners. Dr. Agarani and Dr. Hamira are in the 4th and 5th position. Thank you all.
So come to an end of this very innovative and
quite
very nice
of good standard
presentation. Yes, and quiz conducted by Dr. Rajesh and Dr. Archana are excellent. I must say that it is really very good.
Rajesh, it was up to quite a standard question with the latest guideline. All the PGs should be aware of these. So I must thank Dr. Parag sir once again, Dr. Sarita Balirao madam, ICOG secretary, and of course to the President FOGSI, Sunita ma'am. My gratitude is always there, and Suparna Khadilkar madam, Secretary General FOGSI. So thank you, Parag sir, for giving FOGSI Quiz Committee an opportunity to be associated with ICOG, and I hope this is going to be a very exciting event of this ICOG PG clinic in future also. This time we had very short notice of 2 days. So next time we are going to be, of course, the questions were very nice, but can we think of giving something to the quiz winners so that it is like some kind of incentive to them to join and to be a part of it?
Certainly, we
So
can
I'll
think
just-
about it. Actually, it is the innovative addition in the curriculum of the ICOG PG clinics by Dr. Parag Viniwale. I
Yeah.
congratulate him for this, and this is an excellent effort. And I believe that the acceptance of this program and the attendance will be improving in a much faster rate. So we have Parag with us. So if you want to share a few words with us, kindly share.
Sure. Thank you, Ashish. First of all, Archana and Rajesh, congratulations. Very well done. I
Thank
know you had only 2 days, but you all are experts, and you are the real quiz masters. So you can do magic 1 or 2 days.
Thank you,
right?
sir. It was all because of you.
No. So we still have about 11 more programs to go. So your the committee is required in each program. Of course, next time onwards, we'll tell you the subject well in advance so that you can.
We can actually
have
give
better
some kind of
preparations.
certificate to them, like PG, ICOG clinic quiz winner, something like that.
We will be for the first 3 winners and Team Aristo. Please note their names and numbers, and we will be giving them a book as a gift because we don't want to give anything, but then book is something which will be useful to them.
Yeah, of course, that is the best gift to give.
So this is what we had decided in the office bearers meeting, which we had during the AICOG. So. But all in all, it was really very well done. Good job, Rajesh.
Thank you, sir. Thank you.
And thank you, Ashish, for being so patient, sitting in one place for 3 hours. Conducting the program is not easy. I really appreciate your efforts. Thank you so much.
Thank you, Ashish, sir.
And if Hafizur is...
Hafizur has
thank
a
you,
good
Hafiz.
connection.
Yeah, Hafizur is always doing coordinating so well.
Hafizur has a poor connection, I heard. So this is nothing to take away from him because he's always present, omnipresent. And he's always very, very enterprising in organizing anything. But time has come that we'll close it now because otherwise they will demand lunch now from ICOG. Parag, thank you very much for the excellent addition.
Thank you, sir. Thank you, Ashish, sir. Thank you, Parag, sir.
Archana, and thank you, Rajesh. Excellent program, and the Kahoot app has done wonders. I think very intelligently played by the quiz masters, and I think this is going to continue, and we have a lot of scope of improvement also. Just to take care of the lunch time. That's all. So we will decide about them in future. Maybe we can give a lunch break also. We'll think about it, and we'll come back to you. And till then, goodbye and thank you on behalf of ICOG. I take the liberty of thanking you from the chairperson, the secretary, and the entire ICOG body. Thank you for this excellent thing, and this will be a very good addition in the ICOG PG clinic. Thank you very much. Thank you very much.
Thank you, sir. Thank you, everyone. So, Parag sir, we just wanted a picture. Rajesh, have you taken some pictures? Parag sir.
Yeah, take some picture. Parag sir has gone.
Parag sir,
please
be
visible.
Take some pictures. Yeah, you have taken.
Parag sir को phone करके बोलना पड़ेगा. 1 minute.
And Professor Monica was very enthusiastically answering also. I was just going through it. Thank you, Monica ma'am.
1 minute, मैं phone करता हूँ. हाँ.
पराग सर के साथ एक पिक्चर होना है.
हाँ, होना चाहिए, right.
Shobha ma'am,
Dr. Ashok Kumar
Shobha ma'am, Shruti ma'am, if you are there, please just make your video visible. We'll have a screenshot. Durga Shankar Das sir is also here.
I was also wondering, ATCOM is a part of medical education. As an MRCOG, they have some kind of questions on how to counsel patients. You had a hysterectomy. that needed to be opened, how to do it, why a patient had a PPH. The attendant is, shouting over the doctor. So if they can be having a counseling session, some kind of this exercise could be included in ICOG classes. It will give a insight to the students how to handle these difficult patients and can decrease violence against doctors. Some role plays can be done actually. One acts as a patient, one acts as a doctor, and then these difficult case scenarios, the counseling skills in some of these ICOG sessions. Just a suggestion.
So that is a good suggestion because ATCOM is one area where we have to evaluate PGs now. We are doing evaluation under that heading also during their exams.
So that may be included in a few of the sessions, difficult questions. Case scenario.
Yeah, Parag sir, aa rahe kya?
Yeah, he's coming. He's seeing the patient. He said, okay, I'll come for 2 minutes. Just yes, sir. Bolo, huh? Okay. So I'll come. हाँ अच्छा ठीक है मैं बोल देता हूँ उनको ठीक है ओके नो प्रॉब्लम थैंक यू हाँ Parag just rang up and he said that he's not being able to find the link, so internet connection नहीं आ रहा है उनके वहाँ.
Oh, अच्छा.
Patient तो बहुत है.
I have taken a pic, madam.
So Rajesh ने लिया है, so we'll just say goodbye. Thank you, sir.
Share कर देना हाँ. Dr. Shruti has come back.
Shruti has come back.
Yes. So we can include another picture and you can take another picture and include Shruti in it. Dr. Shobha, are you there?
Rajesh, you also take some pictures because I have logged from mobile, no?
Yeah, I have taken, madam.
Thank you.
Thank you.
Thank you.
We'll share the pictures.
Sir. Thank you, Manika, madam.
Thank you so much.
Share the pictures, okay?
Okay.
Yeah, sure.
Thank you. Bye.
Thank you so much. So from here, I'm ending this meeting.
Bye. Thank you so much.